Hello friends, on behalf of Indian Chess Society, I extend you a warm welcome to all of you today evening for this webinar. I am Dr. Rajesh Swarnakar, Secretary of Indian Chess Society and consultant pulmonologist practicing in Nagpur. Today's webinar is first in part of 4 web events that we aim to bring to you on a topic not much discussed in pulmonology, that is allergy and immunotherapy. As you all know, allergy is overreaction of the immune system in certain individuals to some harmless substances. And the common allergic disorders are asthma, allergic rhinitis, anaphylaxis, drug, food and insect allergy, eczema and urticaria. There have been a recent increase in incidences of allergic disorders which actually cannot be explained by genetic factors alone. Maybe infectious diseases during early childhood, escalating environmental pollution and allergen levels, and dietary changes with increased use of junk foods are some of the important factors for major allergies, and mitigating them is a major challenge we all are facing. So, quoting from the National Health Portal of India, which is a gateway to authentic health information pertaining to India, approximately 20 to 30% of population in India suffers from at least one allergic disease. Out of this, about 15% develop asthma. Urban children have higher prevalence with a male predominance. About 4.5% of adolescent population is allergic to certain foods, items leading to asthma, allergic rhinitis or both. So there is a lot to discuss and learn which prompted us at Indian Chess Society to bring to you a whole web series on allergy and immunotherapy topic, where stalwarts in the field will guide us to understand, diagnose and manage them effectively. So it's my privilege, friends, to introduce you to our faculty and the topics for today's webinar. So to begin with, we'll touch the base with basic immunology related to allergy, and this will be taken by none other than Dr. Saibal Moitra, who is adjunct professor and senior consultant allergologist at Apollo Hospital, Kolkata. And thank you, Dr. Saibal Moitra, for also the brain behind these modules. Then next will come to the aerobiology of outdoor allergens, and this would be taken by another as stalwart, Dr. A.B. Singh, who is a research scientist in allergy and allergens, and he is also scientist emeritus of Institute of Genomics and Integrative Biology. He has put in his research into aeroallergen research, allergic vaccine production, allergen characterization, monitoring of bioallergens. He is president of Asian Pacific Association of Allergy, Asthma and Clinical Immunology. His credentials are so much that it cannot be told in short, and hence you can actually call him Aerobiology Singh, that is AB Singh for you. Then how to test the allergy. So we will have a topic on allergy skin testing, skin prick test by none other than my friend Dr. Indranil Halder, who is both pediatrician and a pulmonologist by qualification. He is also passed the Hermes Adult Respiratory Medicine examination. He is associate professor, Department of Pulmonary Medicine, College of Medicine and JNM Hospital, Kalyani, Nadia, the West Bengal University of Health Sciences. And after the skin prick allergic test, what about this in vitro test for diagnosis of allergy, which are being done by many pathology labs? So we have our own Dr. D.J. Christopher, who's Professor, Department of Pulmonary Medicine, Christian Medical College, Vellore, and immediate past President of Indian Chess Society and currently Research Chair of ICS. He also happens to be the course director of Diploma in Allergy and Asthma, which is the course which is actually run by Christian Medical College, Vellore. And in the end, we'll again have Dr. Saibal Moitra, who will be talking on anaphylaxis. So Welcome all of you to this very enlightening webinar on the topic, which will be interesting. And finally, in the end, we'll have a question and answer session with our distinguished speakers where they will answer queries, doubts raised by our esteemed audience today. So request you to kindly to post your questions in the chat box, and we'll try to take as many in the time we have. So let the ball be rolling, and I invite at the outset Dr. Moitra to deliver his opening lecture today on basic immunology related to allergy. Dr. Moitra, please.
The outset, I would like to thank Indian Chess Society for their innovative endeavor of letting.
So I think Dr. Moitra, your audio is a bit low to hear. So
Is it better now?
yeah, it's better now.
Thank you. First of all, I would like to thank the Indian Chess Society for taking up this endeavor to bring this web-based teaching module on this topic of the allergy. And thank you, Dr. Swarnakar, for just to give a very fitting start to this web webinar. Usually, whenever we start to talk about allergy is a science, clinical science, which is based on the basic science of the immunology. So usually we would like to start this series of the webinar on having the first lecture to know the basics of the immunology and the allergy, which will help us to understand and the later topics much better. Allergy is a very old disease. So it has been reported in the antiquities by one of the pharaohs, that is Pharaoh Menes, who was thought to be died of some wasp sting, though this is a debatable issue now. But at least it says one thing, that is it is a very, very old disease. But it had no good explanation till 50 years ago, when more scientific evidences of this allergy science started to come in, and we started to know more and more about the mechanisms of these diseases. The history of allergy, if you look, it was in 1890 when Dr. John Bostock, he said about the hay fever. Then 1906, it was the Clemens von Pirquet from Vienna who coined the term allergy. But at that time, the term allergy, what he meant is basically it is a response of the body to any foreign substance. The response could be beneficial, which he coined as immunity, and the response could be harmful, which he said as hypersensitivity. But with the time, this allergy has become synonymous with the harmful aspects of this response. That is, now we say the hypersensitivity and the allergy. That is the two terms we use. But it was not so when it was coined by Dr. von Pirquet. Then in 1921, Prosnitz and Kusner, they came up with the passive transfer of the positive skin test, which is called the PK test. And in 1923, the Koka and Cook coined atopy. And in 1968, the breakthrough happened when the Ishizakas and the Johnsons, they discovered the immunoglobulin E, that is the IgE, which is the prototype antibody which mediates these allergic reactions. So if you look into the definitions of what is immunology, immunology is a study of the immune system. And this immune system study studies all the aspects of the host defenses, which is needed for any combating an infection, or also the study of the adverse consequences of the immune responses, that is the hypersensitivity or maybe the autoimmunity. An immune system, it consists of the tissues, cells, and molecules which is involved in fighting the organisms, or it is involved in basically to fight the tumor cells and to maintain the body homeostasis. So the main role of the immune system is defense against microbes, number one. Number two is defense against the growth of the tumor cells, and the homeostasis, that is, it is needed for destruction of the abnormal or the dead cells, and thus to maintain the normal constituent of the human body. So when we think about where these cells come from, they originate from the bone marrow. It is the pluripotent hematopoietic stem cells which gives rise to the common myeloid lymphoid progenitor, which forms the B cell, T cell, natural killer cells, which goes and populate the lymph nodes, and then they become the activated T cells or activated natural killer cells or the plasma cells, which produces the antibodies. And they are mainly the cells of the adaptive immune system. From the bone marrow, there is also another population of cells that comes from the common myeloid progenitor, which gives rise to the granulocyte macrophage progenitor, which forms the granulocytes in the blood, and in the tissues it can form the mast cells or the macrophages. So all the cells of the immune system, they come from the bone marrow. So, and then we know that immune system is basically, it is two arms. One is the non-specific innate immunity or innate immune system, and another is the more specific adaptive immune system, and both has its own cellular components, that is cells, and the humoral components, that means the soluble proteins, and so which are important for maintaining or for carrying out the defense and mechanisms of the immune system. So innate, we know that it's a non-adaptive, the first line of immune response, and relies on the mechanisms that exist before the infection. But the acquired adaptive, it comes later, the second line of response, if the innate fails, it relies on mechanisms that adapt after the infection and is handled by the T and B lymphocytes. So it is called an adaptive immune response, and is very, very specific, and one cell determines one antigenic determinant. So if we look into this schematic diagram, initially it is the anatomic barrier, that is the skin, oral mucosa, the respiratory epithelium, and the intestinal mucous membranes, which is the anatomic barrier, part of the innate immune system. Then there is a complement of antimicrobial proteins like the C3, the defensins. Defensins are the small proteins which gives protection against bacteria, virus, fungal infections produced by the neutrophils and other cells. Or we have the Reg3 gamma, which is produced by the Pennant cells in the intestine, and it is required to destroy the gram-positive cocci. So these are all the proteins belonging to the innate immune system. Then they can activate the innate immune cells, and they are mainly the cells of the inflammation, namely the macrophages, granulocytes, or the natural killer cells. And if they cannot handle this innate part, if they cannot handle the infection, then the adaptive immunity comes into play, which is mainly mediated by the B cells and the T cells. And these B cells and the T cells, they are mainly involved for the T cells is for cell-mediated immune response, which eliminates the intracellular microbes that survive within the phagocytes or the infected cells, or the humoral immune response, which is mediated by B lymphocytes. It is mediated by lymphocytes, eliminate extracellular, mediated by antibodies, eliminate extracellular organisms, microbes, and their toxins. So this is how the T cell and the B cell recognize the antigens. So the B cell receptor just looks like an antibody. So both have their variable regions, the T cell receptor and the B cell receptor. And through this variable region, they recognize the antigens. Then they have the constant regions through which they mediate the particular function. And they have a transmembrane region through which they attach to the cell membrane. And when this transmembrane region it goes away, so these B cells can form the soluble part is only variable and a constant region, which is called the antibodies. So actually this is almost similar, that is they through this variable region, they will actually recognize an antigen, and this variability, it gives rise to the specificity of the adaptive immunity. So this is a schematic flow chart which shows that this is the follow which is being followed by usually any infections in the body. This infection is first recognized by the antigen presenting cells, and these cells presented to the T cells. These T cells can either kill the infection and through the affected T cells, or they can help the B cells to make the antibodies, which then actually helps in killing that infection and also blocks the new infection. So these antibodies are the main effector molecules of the humoral immune system. They belong to the gamma globulin fraction of serum proteins, and they have the Y-shaped or T-shaped polypeptides. There are two identical heavy chains and two identical light chains, and there are 5 kinds of antibodies: IgG, M, A, D, and E. So now we come to the allergy. So allergy is the exaggerated or it's an altered reaction, and it is mediated by the IgE antibodies. It is against the harmless substances which we call the allergens, because this is otherwise they don't cause any harm, but the body sees it to be a threat and they mounts a reaction against it. And the result is a harmful inflammation. So this is what an allergy is. So we have these three terminologies which will be used time and again when we talk about the allergic diseases. One is atopy. Atopy is a genetic state, that is, it is the tendency to actually produce the IgE when they encounter a harmless allergen. Sensitization is the immunological state, and the allergy is the clinical state. That means mere presence of the IgE in the blood or IgE bound to the mast cell is called the sensitization. It may not give rise to the clinical disease. So when the specific clinical disease is caused, maybe the allergic rhinitis, the asthma, atopic dermatitis, that is the allergy. Otherwise, presence of the IgE is not allergy, it is a sensitization. So this is of paramount importance to understand. And this antigen, it provokes the immune response, and the antibody, it antagonizes the antigen against which this allergen, and against then these antibodies are produced by the body, and which could be of various classes. In allergy, it is of IgE class, and the receptors are basically receive the signal, and then they pass on the information to the cell to react. And we have seen that there is a B cell receptor and there is a T cell receptor. And the interleukins, they are the proteins which mediate the communication between the cells, and they are mainly the communicating molecules through which all the cells of the immune system, they communicate with each other. And this communication network is very important because they actually help in either they help in halting an immune response, or they help in basically exaggerating an immune response, depending upon the need. So the multiple cells are involved in the allergy. It could be a mast cell, which is when the Ig gets bound to its surface to high affinity Ig receptors. It could be a eosinophil, which brings about the inflammatory reaction. It could be a basophil, which has lots of granular contents in it, and it can release it. Granular contents on activation. The T lymphocytes are the master cells, and the B lymphocytes are basically the facilitator cells, which helps in facilitating in the allergic response in an individual. This is a schematic diagram of a mast cell. The mast cell in the cytoplasm has numerous granules, and in its surface it has this high affinity IgE receptors, and this high affinity IgE receptors, as when there's the allergen that comes and binds to the IgE, which is bound to the high affinity Ig receptor, it can cause its cross-linking, which is called a coupling reaction. And this actually then leads on to a various signal transduction mechanism, ultimately culminating in the release of these chemicals which is there in the granules or in the mast cell cytoplasm. And these mediators or the chemicals brings about the typical inflammatory reaction, and this could be the histamine, tryptase, peptide activating factor, lipid proteases, chemokines, cytokines, endothelins, nitric oxide, and there's lots of these chemicals are released. Now it has been known that mast cells are also involved in coagulation, cascade, host defense, and tissue remodeling. And it's very important to remember that mast cells do not circulate in the bloodstream, they remain in the tissues. So lots of mediators are involved, as we have just discussed. It could be histamine, tryptase, kinase, leukotrienes, prostaglandins D2, to name a few. And the basic defect in the allergy is, number one, is the epithelial defect. And this is because of this epithelial defect, these allergens gain entry into the submucosa. There is an environmental agents, the trigger factors, which could be an indoor allergens, outdoor allergens, foods, insects, drugs, and many things. And then there's the gene and environment interaction. So this allergic disease is a classical example of a disease occurring because of the gene environment interaction. And this leads on to a immunological state, that is a sensitization, which can lead on to an allergic state, that is specific allergic disease. There are certain facts, but this can be confusing. you can be atopic but not allergic. That means genetically somebody may be programmed to produce the IgE, but that does not mean that individual will have an allergic disease, because it is only when there's some environmental triggers they come and there's a gene environment interaction, then the disease can manifest. Then and one can start producing the IgE. That means one can become sensitized, but again one may not be allergic. The disease may not be there. So it requires several steps, and which is being controlled by numerous cytokines, numerous cells, and these are all the complex steps which is involved. And so from atopy to sensitization to the allergy, these steps needs to be fulfilled in an individual. If an individual who is genetically programmed, staying in a particular environment, becomes an allergic. So if you're allergic, you're always sensitized, but the opposite may not be true. So this is what happens. And this is a mutant epithelial membrane. You can see this is the airway lumen, and these are the epithelial cells, and these are actually the junctions. And these junctions are not very tight, and this junction disruption, it is being caused by the pollution, the viruses, the proteases, because there are these cells and these proteins, that is occludins, claudins, the scatterins, and this actually their destruction of these proteins, which can cause these tight junctions to be disrupted, through which the allergens can gain entry, which is then taken up by the dendritic cells or comes in contact with the Th2 cells, and then it mediates the typical allergenic cascade. This is because of the epithelial junctional barrier defect, which is one of the important defect, the epithelial defect, which leads on to the allergic disease. So this is a very important diagram which shows that when, because of this defect, the allergen gains entry into the submucosa, it is taken up by the antigen presenting cells, and then they present it to the Th2 cells. And when there is a suitable signaling from these antigen presenting cells, these Th2 cells will lead on to the secretion of cytokines and interleukins, which are the communicating molecules. It is interleukin 4 and 13. It will cause a B cell to produce the IgE. Then this IgE goes and binds to the high affinity Ig receptor present on the mast cell. Now till this time, there is no clinical signs and symptoms. It is only the sensitization phase, and this Ig is produced, and the Ig has gone and got bound to the high affinity Ig receptor on the mast cell membrane. Now when this antigen again enters the body, and it gets binds to the bounded high affinity Ig receptor bounded, or a mast cell bounded the IgE receptor, IgE, and then there is a coupling reaction, and which then causes the signals inside, and this causes the mast cell activation and degranulation, releases the mediators which brings about the pharmacological and clinical effects, and numerous cytokines which then causes the inflammatory cell activation. So this initial exposure, after that this presentation by antigen presenting cell, the T cell response, B cell response, and the sensitization state. When there's a re-exposure, there's a coupling reaction between the two IgE, which is bound to the mast cells, release of mediators, and tissue reactions, inflammation, then it is the allergic reaction or a typical allergic state. So the IgE production, it is controlled by the T cells. This T cells commands the B cells to produce the IgE through the release of the cytokines, namely interleukin 4. This is the main cytokine which causes the B cells to produce the IgE. That is as the class switch from the initial IgM to the IgE, and interleukin 13 is also involved. And this Th1 cells will in turn inhibit the Ig production through the interferon gamma. This is an antagonistic reaction. And there's always an antagonistic reaction or mechanism present in the immune system, which actually prevents the immune system to go haywire and keeps a check on in every step. So in every step, there will be antagonistic reaction in the immune system. So the allergic reaction has two phases. There's an early phase within minutes and lasts for 1 to 2 hours. And there's a second wave, is the late response, which starts after 6 to 8 hours. The late allergic response lacks the speed, but it is huge because it involves lots of other mediators, lots of other cells, and has many clinical implications. and this is the main reason for the tissue inflammation. So these are the differences of the early phase and the late phase reactions in an allergic reaction. Early phase is the response within minutes up to 2 hours. Main cell is the mast cells. Main mediators are the histamine, which is already preformed. It is not needed to be means it's produced, and it is only needed to be released by the mast cells. There are very few cells, and treatment is usually the antihistamines. It can and it can abrogate the function of the histamine. The late phase reactions, it starts a bit late, from 2 to 8 hours, and predominant cells are lymphocytes, neutrophils, basophils, and the mast cells. There are multiple mediators which are involved in this, which is can leukotrienes, the prostaglandins, the platelet activating factors. So there's chemokines, the cytokines. All these is mediators, as they are, and cyclooxygenase and cyclooxygenesis, that's the arachidonic acid metabolites. All these are mediates the late phase reactions, and they are formed after and they require some time because for the translation and transcription and translation of the proteins, so it takes time, and this leads on to the inflammation. To treat this late phase response, usually it is treated by steroids and at certain time the anti-leukotrienes. And so the message to be taken is that it is the T lymphocyte which is the king cell of an allergic reaction, which gives the commands, and the B lymphocyte is the worker cell taking the command and producing the IgE, and eosinophil is the inflammatory cell that confuses us all, but it is not the hallmark of allergy. Main driving cell is the T lymphocytes. So allergy is an immunological reaction. A classical example of a gene-environment interaction is any allergic disease. T lymphocyte is the culprit cell because it actually orchestrates the entire allergy cascade, and it is an old disease, but with time we are understanding more and more about its various pathways, about various mechanisms, the various cells, the various molecules. We are understanding more about the innate system and the adaptive system. So this is helping us a lot in understanding the disease pathology and also in developing the newer diagnostic and the treatment and medicines to combat this increasing scourge in worldwide. Thank you very much. So this was just an introduction of the immunology and the allergy, which is definitely is going to help us to understand in detail the disease which we'll be studying in studying later, and also in this module and in other lectures in the subsequent module. Thank you.
Thank you, Dr. Moitra, for a lucid presentation of a very complex, which I seemingly sees to be a complex issue. And as I said, that we would take the question answer session at the end of this session. So I would request audience to keep on posting after each of, I think, the lecture, whatever questions you have. And I suppose that we will move to the next lecture by the stalwarts in Aerobiology. I suppose Dr. A.B. Singh is here with us, and I would straight away invite him to just give this lecture on Aerobiology. I have already introduced him at the start of the webinar. I would just request her to start as just PPT on Aerobiology of allergy.
Thank you, Dr. Sankar. It is a great pleasure to be here this evening. And I thank Dr. Moitra and the team for making it possible for me to be here. I had some initial issue. Just now I could join the webinar in time. So I would like to share my slides.
So my frame is frozen or something? I don't know.
There is some...
some technical glitch. So,
Rajesh, what I think, if the slide is shared with the team, support team, they can move on with the slides.
So, okay, Priya, are you there? So, I think he hasn't shared his slides.
Yes, sir, I'm
Can you
here.
see the slides?
No. So, I think Priya, if the tech team can help.
Absolutely, sir. Sir, I think there's some network issue at Dr. Singh's site. His video is frozen for us as well.
Okay. So
Let's go to the next lecture and then we
yeah,
can.
so is it okay that if we go to Dr. Indranil Haldar, a lecture of how to test by doing a skin prick test, allergy skin testing, and maybe later we can come to this lecture of aerobiology. Priya, is it okay?
It's fine, okay for me.
Dr. Singh, you are there?
Yeah, I'm there. I can listen, but only thing my slides are not there.
Yeah, so I think that meanwhile, if you can share your slides or if you can email me the slides in the chat box, Priya, if you can just put your email or email of the tech team who's going to project the slides.
Okay.
Meanwhile, at the end of this lecture, I think maybe we'll be ready and I think we can project the slides from our end and Dr. A.B. Singh, if suppose can see and just give the audio of the slide.
I will try. I will try.
Will that be okay? So if you can just email
That's
your
fine.
slide deck, sir, to the tech team. And then Priya, if you can just put in the chat box the email to which you can send his slide deck.
Done, sir.
Meanwhile, Dr. Indranil, if you can do
Yes.
the honors of doing the next lecture, and we'll straight away go to how to just test this allergy and
So thank you, Rajesh, and thanks to Dr. Shoibal for giving me this opportunity and his full team to be here this evening in this web series of Indian Chess Society, which also I am a part of it. And our next top discussion will be on allergies skin testing, that is the skin prick test. In fact, this is the gold standard when you want to diagnose what the allergy is. After the excellent lecture by Dr. Shoibal, now we have to identify and have to pinpoint to try to find out what the allergens are. So we have in our armamentarium the in vivo diagnostic test or the in vitro diagnostic test. The in vivo diagnostic test is include the skin prick test, the intracutaneous test, and also some other tests which are there. The in vitro diagnostic test, the serological and the cellular test, the IgE determination, or some of the basophil activation test. And in the top of the pyramid, if we go, there are other tests which include orgal challenge and provocation test. But what is important is that the skin prick test is the preferred technique for diagnosing IgE mediated hypersensitivity. Not only that, when we think of skin prick test, always we have to have a medical history and the physical examination of this subject. This is done after obtaining a detailed allergy focus history, and that is more important. Without a focused history and without finding out what the allergen may be at random, doing 60 or 120 allergy tests is not good, or it should not be done in that way. So how this is done? In the next few minutes, what we are going to do is to present how an allergy skin prick is done, how easy it is to do, and what are the precautions that we should take while, and how do we interpret the allergy skin prick test. So when we, after a detailed history and physical examination of this subject, that we want to do a allergy test and to find out what the allergens are, we do a registration of the patient, where the patient waits in the registration area for consultation. And by that time, the subject should have an idea what we are going to do, that it is not a painful test and that is not going to do harm, and how safe the test is. For that reason, material available in the consultation area, patient education leaflet and posters may be there, so that if subject comes to know that what is been going to done to him. Consultation. Here is the in-depth history taken by the consultation using the allergy questionnaires to identify the need for specific allergy diagnosis, and then have to put on what allergy we have to select for that particular patient, knowing into the full history, when he suffers, where he suffers, and at what time of the year or what time of the season the patient suffers. Coming to the skin test proper, the patient undergoes this test, which is the gold standard allergy diagnostic testing. And the most important thing that we have to use is a standardized allergens and the equipments that should be there. After the test is done and the interpretation is there, the post-test counseling on the avoidance measure and the reference material that is to be given, what are the allergens that is positive and how he should avoid, or whether we should go for immunotherapy or not. Based on this result, other tests may be required. The patient will be guided for further evaluation as to find out what his cause of the allergen is. This is in short how this has been done. A standard allergen, we have the skin prick lancet. The allergen is placed on the skin surface. We'll come to that. Prick is done, and after 15 to 20 minutes, we see whether it is positive or negative by the result that we see and by the will that is been produced, and it is validated. So coming to what are the indications for the allergic test? As we know that it is an IgE-mediated allergy disease, and the most two important condition where we do this allergy skin prick test is in patients who are having allergic rhinitis or an acute urticaria and eczema. There are also other indications where there is an food allergy has been suspected, or in allergic asthma. So there are some other indications for doing a skin prick test also, and that includes some suspected latex allergy, conditions in which specific IgE is considered to play a pathological role, for example, in some suspected or selected cases of chronic urticaria. And also, as a pulmonologist, in order to diagnose allergic bronchopulmonary aspergillosis, we do skin prick test to see whether the subject is hypersensitive to that fungus or not. In eosinophilic esophagitis or eosinophilic gastroenteritis, sometimes skin prick test is also advised. So now coming, what are the situations where we should not go for a skin prick test? There are some clinical situations which interfere with the procedures. For example, if there is an absence of abnormal skin and the skin is eczematous, dry or something like that, then patients who are having dermatographism, where the interpretation of the result may be difficult, and if the patient has taken medications, for example, antihistaminics, high doses of steroid that might inhibit the skin prick response. There are some relative contraindications related to the safety and the high-risk situations. For example, in patients with severe unstable asthma, we may provoke their asthma, who are on beta blockers, in pregnancy, and in highly sensitized patients. So this is practically very important to know when we are advising a skin prick test. What are the medications that should be avoided or have a suppression effect in the skin prick test? When it comes to antihistaminic, we have to know whether the subject is taking a first generation H1 blocker, and it should be avoided for more than 2 days. And second generation, for example, cetirizine, loratadine, or fexofenadil, it has to be avoided for more than 7 days. Steroids, topical at least in the site area for more than 7 days. If the patient is having systemic short-term steroid up to 10 days, less than 50 milligram equivalent, then it should be more than 3 days, and more than 50 milligram equivalent, it should be more than 7 days. When it comes to long-term, if the patient is on 10 milligram per day prednisolone equivalent, there is no need to delay the test, but it is more than 10, we can delay the test for at least 3 weeks. Other drugs like omalizumab, antidepressant, phenothiazine, antipsychotic, there is some recommendation which you have to follow, which may be in months or days. What are the prerequisites? The most important is the standardized allergen extract, the negative control and the positive control, which usually is histamine and saline, the lancet, which I will come to it, antiseptic swabs, which include the spirit swab, normal saline also, disposer for the lancets, marker pen for the skin, rulers, tissue for wiping solutions, and record sheet. And at this time of the COVID, we have to have a self-protection with gloves also. The patient needs to be in a comfortable position, which is very important, with the forearm or back as the convenient. The procedure should be explained to the patient. That is very important because there is always a fear. Mainly, we're coming for the first time there, and patients have to avoid the interfering drugs. The area to be tested should be exposed with no risk of clothing, bruising across the test area, and wiping the test solutions. And as repeatedly told, what is more important with standardized antigen in the gold standard for allergy diagnosis, if you see the IACI position paper or the American Academy of this asthma allergy, they all states that use standardized extract. Allergy extract used for testing ideally should be in the known composition and potency, that is, it should be standardized. So what are the places where you do the allergy test? The selection of the site. Generally, the most convenient and frequently used sites are either the volar aspect of the forearm or the outer upper arm or the back. Test should be applied to the volar aspect of the forearm, at least 2 to 3 centimeters from the wrist and the antecubital fossa. We should just leave that space. The back is especially important in infants. The skin on the back should be known that it is more sensitive than the forearm and result in larger wheals, and thus possibly a greater number of positive tests may be yielded, and we should record where the test has been done. And this is the position of the subject. The subject, as told, should be comfortable chair with armrest for the patient undergoing the test, and the performer should also be seated in a chair. And this is the trolley stool to keep the allergy extract while we are doing the test, and other instruments. We'll come to what are the resuscitation kit and where it should be kept and where, and what are the resuscitation kit that should be available in the clinic for doing the skin test. So again, and highlighting that the standardized antigen, which is to be stored in the proper condition, the ideal situation, it should be stored in 2 to 8 degree centigrade. And about the lancet, which I'll come to, that is the size of the lancet, what the lancet should be, and the measuring scale, the willometer as it is called, so measuring the amount as whether it is positive or negative. So these are the 2 lancets that are available in the market, but the one with a 1 millimeter minimally invasive tip is the one that should be selected, not the 3 millimeter, which will cause more damage to the skin, pain, and blood may come out because of this. So the best one is the one with the 1 millimeter tip. So next is, before the test, the skin area of the test should be clean of any skin lesion. The skin care product should be removed. Medication, as already discussed, should be asked. Mark the test site, that is very important. Check the test solution and the stability and the identification, and how do we mark that? So we have to know that what are the number of antigens that we are giving. 2 to 3 centimeter space should be given. For example, if we are doing in the row 1 and 2, so here we can place at least 7 to 10 antigens, and on this row another 7 to 10 antigens, and again 2 to 3 centimeter space in between the 2 antigen, labeling in alphabetical and in the 2 row A, B, and here we can use 1, 2, 3, 4, 5 as, and according to the known antigen, and we should keep a record what the number 1, 2, 3, 4, 5 stands for in each case. As told, the volar side of the forearm is the site usually preferred, and what we do is that apply a drop of the respective antigen to the mask skin, and which is 2 to 3 centimeter apart. Then what we do is to prick the skin with the lancet, which I will show how to do it. But most important thing to keep in mind is that we cannot use the same lancet for the full test series, and we have to use a separate lancet. Separately remove any test solution remaining on the test site couple of minutes after pricking the skin. Then for that we can use a blotting paper, and ultimately after 15 to 20 minutes it is recorded. And this is how we apply the antigen with the dropper that is there. Each antigen has its own dropper and this cap so that we can use it. And this is the prick. The most important way to prick is that we can use the lancet just pricking inside at an angle of 45 to 60 degree and just gently lift the skin. This doesn't cause any pain, neither any blood to come out of the skin prick site. And this is what happens after 15 to 20 minutes, the wheel reaction, and now that it is recorded with the wheelometer, and see what is the size of the wheel. And as per standard protocol, a diameter of more than 3 millimeter is considered as a positive and less than 3 as a negative. And the control should be there. negative control and a positive control, which we usually take histamine and saline for that. Now, this has been discussed by Dr. Shaibal about the sensitization and allergen. A positive result on the skin prick on a serum specific IG may or may not be clinically relevant, but when it correlates with the clinical history and a positive result is there, then we should think that it is clinically relevant. Now again, it is thought to be a very safe procedure, but definitely there may be some anaphylactic reaction in a few of them. Systemic side effects are very unlikely for the known commercially available respiratory allergen, but again, rare reactions may occur. And though it has been well established that it is a safety of the skin prick test, however, all of the staffs who are there in the skin prick test room should be trained to recognize and treat reaction in a setting equipped with emergency medicine. Now comes, what should the emergency tray look like and what should be there? In fact, the medicines that should be there to manage anaphylaxis, and which will be discussed later on how to manage an anaphylaxis: adrenaline 1 milligram per ml for injection or an auto injection if it is available, antihistaminic steroids and a vasopressor for injections, bronchodilators, which may be in the form of nebulized bronchodilators, the rapidly acting beta-2 agonist, or for intravenous use. Definitely others, saline for infusions, syringe needle tourniquets to make a channel. The airway management should be kept ready, which includes face mask, a nasal cannula, oxygen should be available, and a sucker instrument. Definitely the blood pressure measuring instrument and the stethoscope should be there in the emergency tray. So with this, I thank you all and will be ready to answer the questions in the end of the full session when we will be sitting for answering. So thank you, and over to you, Rajesh.
Okay, thank you, Indranil, again for a very basic into the skill allergy testing. Although there are quite a challenge that we have when we do a SPT, in fact, in India, because we don't have standard allergens and all those things. But of course, we'll of course discuss all these things, and we also don't know what to call NSAIDs, which are there of 1 mm. What are its availability issues and all, and also shelf life, and all those things are there that actually we can discuss. I have been told by Priya that Dr. A.B. Singh is still not able to load his slides and PPT, and there is some issues of connectivity at his end. So I think we will straight away go with Dr. Christopher's lecture on in vitro testing of allergy, which is being very popular because SPT is not available everywhere, and people have banged on this and they have got commercialization of this test, and this is quite available, and it is available widely, and all the pathology labs are really investing into that because of absence of SPT test. I would like to ask Dr. Christopher about this, and I would just straight away invite him to have this lecture for us. Dr. Christopher, can you?
Thank you, Rajesh.
Yeah.
Can you see my slides?
Yes, sir. Go on.
Okay. So I just wanted to, I understand that we have a large clinical group that has tuned in. So I will just broaden my topic to cover the investigations that one would desire to learn in order to manage allergy. So tests for diagnosis of respiratory allergy is my topic. So I will start with spirometry. Although the diseases of lung and bronchi are more frequent than heart diseases, and spirometry is excellent in exclusion or confirmation of asthma and COPD than ECG for coronary artery disease. But an ECG machine is found in every clinic, every hospital. But sadly, even some pulmonologists don't use spirometer regularly or as much as required. In fact, everyone who manages respiratory disease should have access to spirometer. That includes even general physicians and general practitioners. Now, what is the purpose of spirometry? It is to identify and quantify disease that causes pulmonary function abnormalities, distinguish abnormalities as obstructive and restrictive defects, and to assess the progress of disease, such as Even therapeutic efficacy, is the condition improving with treatment, or is it worsening because that's the natural course of disease? All this can be assessed by spirometry. And of course, a crucial aspect of spirometry is the assessment of operative and post-operative risk. So this is the typical plot that we have seen in physiology labs. And we here see a patient taking tidal breaths. And then the patient is asked to take a deep breath inside and fill the lungs, and then blow as rapidly and as hard as possible. Having done that, few measurements are quickly taken, and today we have computerized machines which do this for us. Earlier they were all metallic drums which rotate, and it was so much more challenging. So the measurement of the amount of air blown out after 1 second is measured as FEV1, and the total amount of air that is exhaled is measured as FEC. And then we calculate the ratio of FEV1 by FEC and put it as a percentage, which is into 100. And these three parameters are sufficient to diagnose obstructive and restrictive disorders with the spirometer. Of course, there are advanced tests to confirm restrictive disorders, but with spirometer, it is just these three key parameters that we need to make a diagnosis. And of course, you may also be familiar with this. So this is the flow time plot. So the individual starts blowing here and continues to blow. So what here is in the x-axis is time. And at 1 second, what happens is FEV1. So this is a time here and flow time plot. If you put the same thing, this is the flow obviously is in volume. So if you put the volume here and the flow here on the y-axis, you have a flow volume loop. This is the expiratory phase and this is the inspiratory phase. So this is just to give you an introduction. And what happens, in asthma is this, that in this flow volume loop, you have a concavity at the expiratory limb, and this is typical of obstructive disorders, and of course, which is also typical of asthma. And this is a typical asthmatic plot. When the test is done pre and post bronchodilator, we see that the test has improved in the post bronchodilator plot. And so this is what we call reversibility. And when this is present, it is typical of asthma. And the GINA mandates that FEV1 increase of 12% and also an absolute increase of 200 ml is essential for diagnosis of reversible airways obstruction, which is asthma. Now, some of the important aspects of this test is that the interpretation depends on reference values. It's not like a blood sugar where the normal range is the same for all adults, but it is, this one changes based on height, age, and gender. So all these variables are taken to ascertain an individual's predicted value, and this is different for each population. So we need predicted values for Indians, which is different from the Western predicted values. And in fact, there's a significant difference between the zones of the nation. So Southern Indian and Northern Indian values are very different. So these should be carefully chosen and used in order to optimally benefit. So this is the peak flow meter. This is a smaller, simple machine which is used for asthma evaluation. So it has a metallic kind of a notch here, which when the patient blows moves depending on how good the flow is. So it's an inexpensive instrument and it builds confidence when patients use it at home because they can see themselves improving. It is simple to use. All it requires is one hard and fast blow, and we take the best of three such efforts, and the measured value is compared with predicted values. Now, not always do patients reach the predicted value. They may have chronic asthma, in which case they may never reach the predicted value. So, comparing with just that may not be satisfactory and may even be misleading. So, we use what is called personal best. So, what is personal best PEFR? This is just the highest measurement achieved when person is free of signs and symptoms. Now, we have to understand that this value keeps changing. This value keeps changing in children as they grow. And it keeps changing in adults as their disease progresses, especially if they are not on good treatment. And so there's a periodic need to readjust this value. And so we use we derive this by giving the peak flow meter to the patient and asking them to monitor themselves for 1 to 2 weeks, record peak flow at least 3 times a day, and then we choose the highest peak flow value and call it the personal best. We use a simple system which is user-friendly for patients. We call it the traffic light zonal system. So if the peak flow value is between 80 to 100, the patients are deemed to be in the green zone, which means their disease is under control. If it is the yellow zone, which is 50 to 79%, it is deemed to be a stage of caution where control may not be perfect and the individuals should meet their physician or at least augment their treatment. And red, which is peak flow reading of less than 50, is a medical alert, and they have to quickly fix an appointment and see their physician. A simple way to ascertain how active the asthma is to record the peak flow value, plot it and bring it. You may see that the red spots, which are the morning peak flows, are lower than the corresponding blue boxes. So everywhere you see this difference. So the morning readings are lower than the evening readings, and this is true for everyone. However, in asthmatics, this difference is exaggerated. So the more the difference between morning and evening reading, the higher is the bronchial hyperreactivity or the bronchospasm. So here in this patient, you can see a recording of 670, which is probably the highest. And you can see that on that day, again, a value of 570. So there's a change of 100. So we can calculate peak expiratory flow variability by this formula: highest minus lowest divided by the mean of highest and lowest reading. So let's go through this. Highest is 670 and the lowest is 570. So the difference is 100 divided by the mean of the highest value. The mean of this two is 620. That is the mean of these two values. So 100 by 620 into 100 is 16%. Anything above 15% is indicative of airway hyperresponsiveness. So let's go to bronchial challenge. This is another physiologic test like spirometry and like peak flow measurement. Here the patients who do not show evidence of abnormality or reversibility on spirometry can then be subjected to this test. So this requires a nebulizer. In the ideal world, it requires what's called a dosimeter, which will give graded doses of either methacholine or histamine. One can pick one of these agents, and then thereafter the FEV1 is recorded at different time points, usually 1 and 3 minutes after administration of a particular concentration of this drug. And this continues till there is a drop of more than 20% in FEV1. At that point, the test is aborted because you have demonstrated that there's bronchial hyperresponsiveness, and then the patient is given a bronchodilator to bring them back to normal. There are indirect challenges which are not so reliable. This involves the use of inhaled mannitol or exercise challenge, And in this case, the fall of FEV1 from baseline of 15% is deemed to be indicative of asthma. This is a methacholine challenge. So you can see baseline reading here, and this is control, means that they just have nebulized saline and then you measure. You are not expected to change much, and that's what you see here. And then there are different concentrations of methacholine, starting with 0.06. Then the patient's FEV1 didn't drop by 20%, so 0.25 is given, and then 0.5 is given, and then 1 is given. So somewhere at this point, you see that the patient goes below the 20% mark, and then you know that this person has a positive bronchoprovocation test, and the test is stopped. And at this point, a bronchodilator is given to reverse, and you can see that the FEV1 has gone back to normal. So this requires a good laboratory and a lot of time. So usually only referral centers use this test. Now I'm going to talk about, we looked at measurements of airway physiology. Now we are looking at measurements of airway inflammation. So there are two ways it can be done: sputum analysis and fractional concentration of exhaled nitric oxide. So the first one is induced sputum for differential cell count. So what is the importance of this? Now sputum eosinophils is a risk factor for asthma exacerbation. It's also a risk factor for developing fixed airflow obstruction. So if somebody has persistent sputum eosinophilia, they are more likely to develop fixed airflow obstruction. And then again, tailored asthma interventions based on sputum eosinophils has been shown to be beneficial in reducing asthma exacerbation in patients with frequent exacerbations and severe asthma. So for these reasons, this test is a useful test. Now, the sputum is collected not directly, but by sputum induction using ultrasonic nebulizer, and hypertonic saline is nebulized, and there's a special protocol which takes about an hour. And then the sputum sample collected is transported to the lab within 2 hours at a temperature of 2 to 6 degrees Celsius. And this requires experienced technicians, doctors, and an experienced lab which is willing to spend the extra time needed to do this test. So it takes about 4 hours for each test, and we can therefore guess that this test is not popular and only referral centers with interest in allergy do it. So we do it, but with a lot of difficulty, and one technician designated for this purpose. Now, what is the clinical value of this? I want to show you the study by Green et al. They took 74 patients with moderate to severe asthma, divided them into 2 arms. One arm they treated as per BTS guidelines, which will be very similar to the GINA guidelines and very similar to how we treat these patients. And the other arms, they used sputum eosinophil counts to decide their treatment. So if the sputum ICS was given, if the sputum eosinophils was less than 3, so they continued the dose of ICS at the same dose. If it was 1 to 3%, the goal was that the eosinophil count should be less than 3%. So if the value was was between 1 and 3%, no change was made. If it was less than 1%, ICS dose was reduced. Obviously, if it is more than 3%, the ICS dose may be increased. So they used this kind of a gradation based on eosinophil counts. And this is the two groups, the BTS group, and this is the exacerbation rate, and this is the sputum management group here. And you can see that the exacerbations are significantly less when the management was based on sputum eosinophil counts. And this difference was statistically significant. Fewer patients were admitted in this group compared to the BTS group 1 versus 6. And interestingly, even though they used variable doses, you would have guessed that they probably gave higher doses of inhaled corticosteroid, which is not the case. So this is the algorithm which specialized centers can use. They can use sputum eosinophils to determine how much inhaled corticosteroids to give or increase or reduce. And if it's an eosinophil-driven inflammation, then they should reduce steroids, but investigate the cause of neutrophilia. Look at molecular diagnostics for infections, try macrolides, use nebulized hypertonic saline and nebulized saline. And now let's look at FeNO in airway inflammation. It is a quantitative, simple test to perform, and today most of us can easily perform this in our clinic. Now, FeNO is an indicator of IL-13 driven inflammation and therefore of corticosteroid responsiveness of the airway inflammation. The advantage, as I said, is the simplicity, ease of repetition, and can be used even in patients with severe airflow obstruction. So this is the ATS recommendation that if the FeNO value is less than 25 parts per billion, it can be used to indicate eosinophilic inflammation and responsiveness to corticosteroids is less likely. So if it is less than 25, the patients are probably controlled or do not have eosinophilic inflammation at all. If the FeNO is more than 50, then we can assume that there is significant eosinophilic inflammation and these patients should be treated with corticosteroids, or if they are already on it, they should have a higher dose. Now, if the value falls between 25 to 50, then it should be interpreted with caution based on the clinical context. So, now, some reasons why this test is not completely dependable or you may have erroneous results is that FeNO can increase when the patients consume a diet rich in nitrates, after viral infections, after bronchodilators, and allergen exposure, and soon thereafter. And it can reduce in smoking, bronchial constriction, alcohol consumption, inhaled and oral corticosteroid use, and spirometric maneuvers. Now let's look at blood eosinophils, because sputum eosinophils, I told you, is excellent but very difficult to do. Thankfully, blood eosinophils have been fairly reliable. So this is a count of blood eosinophils starting from 200 to 300 to all the way to more than 1,000. So this study looks at, obviously multiple studies have been put together, showing that the relative risk of severe exacerbation increases as the eosinophil count goes up. And also acute respiratory events also goes up as the eosinophil count goes up. And the overall asthma control improves as the eosinophil count goes down. So eosinophils are actually not bad. Now, this is a study that compares blood eosinophils with sputum eosinophils and FeNO and IgE for severe asthma. So, in the context of severe asthma, blood eosinophils is obviously sputum eosinophils is the best, but blood eosinophils does reasonably well. And FeNO, of course, also does reasonably well. But if you look at IgE, you find that it almost, it almost doesn't correlate. It almost goes in the opposite direction. So IgE is not a good marker for severe asthma, but the other three are. And thankfully, sputum blood eosinophil will come to our rescue when we need to evaluate this. So let's look at the third aspect of test, which is measurement of allergic status. So allergy skin prick test is already been lectured on. Total IgE and serum specific IgE. So what we have as an in vitro test is an immunocap test. So it is the equivalent of skin test, but it's a test done on blood sample and in the laboratory. It measures the IgE, the total circulating in the serum or plasma, and the units is Ku per liter because of the small concentration this unit is used. And there's marked variation between healthy adults and this changes with age. Up to 10 years, the IG increases, and at 10 years, it reaches its peak, and thereafter, it starts reducing. This is a sample report looking at different specific IGs. And you can see here this elm tree is above the normal, so this is positive. You can see dog dander is positive, Bermuda grass is positive, alternator is positive, ragweed is positive, and orchard grass is positive. So you can look at the different allergens specifically and look at what the patients are allergic to. So immunocap and skin prick test can tell us if a patient is sensitized, or that the patient is not sensitized to an allergen and therefore is unlikely to have an IG mediated reaction to that allergen. But it cannot tell us the severity of a reaction if a sensitized patient is exposed, or whether the patient's symptoms are caused by the sensitized allergen. Every allergen that is positive may not be the cause of the individual symptom. So a lot of clinical correlation is crucial for optimal use of these tests. So this is a figure to illustrate the role of allergen control based on their positivity. So this is an individual. This is a pollen season when the individual exceeds the symptom threshold. So it's not that nothing is happening. There's a simmering degree of allergic reaction happening, but the symptoms occur only when they exceed the threshold. So this happens for this individual during the pollen season, during the viral infection season in September, and during another bout of viral infections between November and December. So how can we help? We can help by carefully reducing allergen exposure, pollen here, and as much as possible reducing infections, and keeping the individual below the symptom threshold, and therefore reduce or avoid exacerbations and symptoms. The second one is that, we know that allergic disease severity is related to exposure to allergens and the duration of allergen exposure. But there are practical difficulties. Try telling a person who has, let's say, a pet dog to get rid of the dog. We know that it does not happen. But what, therefore, is a pragmatic but practical option is to institute allergen control measures in the home, particularly in the bedroom. And these measures have been shown to be effective. So essentially, we establish an environmentally safe sleeping zone according to the test results, and ensure that the individual does have symptom relief. It also helps to select patients for allergen immunotherapy. So without knowing the individual's allergen sensitization, we will not be able to plan allergen immunotherapy. So these are some of the tests that we have and some of their roles. I am not able to cover everything in detail. Thank you very much for your patience.
Okay, thank you, Dr. DJ Christopher, for just largely covering asthma into your in vitro testing. But if I can ask also Dr. Saibal Moitra to just also give a gist of this immunoassays and allergen specific IGs that I was talking about when I was just introducing the topic, that pathologists are not just doing it. So they are just testing this blood test they take, and they do allergen specific IG test, they do it on drug, food, and all those things. So what is the value of it? Dr. Moitra?
Yes, Dr. Sonika, as Dr. Christopher and also Dr. Halda, they have so nicely elaborated the thing about the allergy testing. So what it is mainly, whether we are doing it by skin prick test, where we are only finding or trying to find out that the mast cell bound IgE is there or not in a particular allergen. In the in vitro test, where we do the ImmunoCAP, which is the WHO standard methodology, it is only trying to find out whether there is the IgE which is there in the blood to a specific allergen. So the mere presence of the IgE is not equivalent to an allergy, which is a disease, which is a clinical condition. So the presence of the IgE only tells us that the person is sensitized to that particular allergen. Now, in any allergy test, so there is always a second history, which we call a post-test history, where after a particular test is done, then the physician has to sit with the patient again with the report and try to correlate that whether before the testing we usually select the allergens depending upon the patient's history, patient environment, patient food habits, and we select the allergens. Then we do the test. After we get the test results, we find the IgE is positive to some array of allergens. Then again, we have to sit with the patient, correlate with the patient history, having a pollen chart and having everything in hand, and only those IgE which is positive to particular allergen is correlating with the patient's history, then we can say that the patient's symptoms is caused by that particular allergen. It is not that having a mere presence of the IgE is allergy, it is only sensitized test. So usually what is done is that when the result comes, that is not the end of it. Usually that does not say an allergy, that is only a sensitization state. So this is very, very important, because if we do not pay attention into it, the entire test or the entire this entire workup, it gets a bad name because it is not evaluated or interpreted in the right sense. So it is important that how we interpret the results in the light of the patient's history and also the patient's disease state. So this is an extension of the talk in the module 1, which has already been taken by Dr. DJ Christopher. So I would like to add some of the topics into it. So this is the in vitro allergy tests part 2. So when we talk about the allergy tests in vitro, and the agenda should be when to test, why to test, what are the options we have, and what is the comparison between the options. Okay, so when an allergy testing is required, so the common indications includes atopic dermatitis, drug-induced skin rash, chronic or recurrent rhinitis and or conjunctivitis, allergic asthma, food allergies, stinging insect allergies, anaphylaxis, and things like that. But the one most important and principle which has to be kept in mind when we're advising and interpreting an allergy test is that, which I have already spoken in the lecture on the basics of the allergy, that there is a temporal relationship between the allergen exposure leading to the allergen sensitization leading on to the allergic disease. But the allergic sensitization and the allergic disease, they are not synonymous. So whatever we test, whether it's an in vivo test by skin prick testing or in vitro test, we actually detect the allergen sensitization. It is not allergy. It is an immunological state that we're detecting. Maybe we are trying to detect some specific antibodies like the specific IgE, but we should not equate that with an allergy. And this is the common fallacy in interpreting the allergy tests. So what happens is that when someone comes with an allergy test report, they say that there may be a few items to which is showing positive, and the doctor or the patient thinks, oh, I'm allergic to this, so let me avoid this. Well, that is not at all the thing. It only means that that particular patient is having specific IgE in his or her blood to that particular items. Now, that having a specific IgE to a particular item does not always translate into having a disease because of that specific IgE, because mere presence of IgE to the occurrence of a characteristic pathologic changes in the tissues which can lead on, which can give rise to signs and symptoms of a particular disease. There are numerous factors as between the sensitization to the allergic disease, and these factors are environmental, genetic, epigenetic, and multiple other host factors are involved. So which is at times many factors we know, many factors we don't know. So only few of the items, and so maybe of the sensitized is means items might be giving the allergic symptoms, or it may not be that also. So this is very important to understand. Why we test the allergy? Allergy testing is very important diagnostic process, because number one, if we want to start a specific allergic avoidance measures and also disease monitoring. That is, when the specific allergen is there in the patient's and vicinity, which is causing the symptoms, and we want to advise allergen avoidance measures, we want to know that what are the specific allergens which is causing the symptoms. Or number two, maybe the specific allergic treatment like the allergen immunotherapy. And C, it is an early identification of infants at increased risk for later development of the allergic diseases, because if the sensitization pattern or number of sensitized items is increasing on a serial allergy testing in an infant, this shows that there is immunological progression underneath, so which might lead on to the particular disease later on, even if the infant is not having any symptom at that juncture. But if there's a family history of allergy and we do a test, there's sensitization or prick test or a specific IgE test, and we find few items which is showing the IgE, then we repeat the test maybe 6 months to 1 year later, and again we see that the number of items has increased. So that means this infant is at increased risk for developing the allergic disease later on. So what are the options we have? We already talked about the skin prick test. This lecture will be talking about the in vitro blood testing, and mainly the focus would be on a specific method of blood testing, that is the immunocap. Okay. So what is immunocap? Immunocap is basically a solid phase assay technique for detecting and quantifying antibodies which is specific to the IgE. We can use other methods also, like we can use an ELISA, that is an enzyme linked immunosorbent assay, or previously we used to use the RAS, that is a radioallergosorbent tests. So the patients with allergy, we know the immune system will produce IgE antibodies in response to allergen exposure, and we detect the specific IgE, that's sensitizing antibodies. And the blood testing is preferred at many a times because it can perform irrespective of age, skin conditions, whatever medication the patient is taking, because there are no interfering medications as is there in the skin prick test. Symptoms, disease activity, pregnancy, we just only simply have to take a blood and do the testing. And the blood testing does not carry the risk on anaphylaxis or triggering symptoms as it is there in the skin prick test. So that's why it is at times preferred. But understand that radioallergosorbent is an obsolete method of blood testing using radioimmunoassay test, which is no longer used these days. We use much better technique these days, and the main WHO standard technique is the immunocap assay. So the clinical utility is, number one, the diagnosis, number two, the prognosis, and number three is the follow-up. So when diagnosis is, that is, detecting the whole allergens is an aid for identifying the offending allergens, identify the patient's sensitization profile, and which helps in individual medical treatment plans, and also evaluate the symptoms or severity due to the exposure, because more the severe, higher the specific IgE to a particular allergen, more chances of the severe reactions or severe symptoms to it. Prognosis is that immunocap whole allergen is an aid in predicting the disease development, helps explain the allergic march, that is from the atopic dermatitis or the food allergy to the allergic rhinitis and the asthma. So if there is number of the allergens and specific IgE to particular allergens increases over a period of time, It shows that the individual is on an allergic march, and therefore this is an important way to diagnose the allergic march. And also it explains the allergen load. Then the follow-up, that is the Immunotherapy whole allergen, is an aid to follow the changes at the patient-specific IgE antibody level over a time. So we can understand the patient-specific IgE to a particular allergy which is being avoided by the patients. If the titer is going down or if it becomes negative, then it shows that the avoidance measures is quite effective in that patient. And so it reflects the effect of the avoidance or the elimination process over a period of time. So before going into the whole allergen test, what we usually do is an allergy screening. How do we screen? The traditional method of screening an allergy is measuring the total IgE. So whenever any patient comes and asks the doctor that I have something which looks like an allergy, doctor thinks that it might be an allergy, and he or she advises total IgE. But always remember, total IgE measurement is not a very good test to screen for allergy. Why? Because it can be increased in parasitic infections, in ABPA, in Hodgkin's lymphoma, in hypereosinophilic syndromes, in EGPA, specific immunodeficiencies like hyper IgE syndrome, viscotalries, digeorges, and very rarely in IgE myeloma. And all these conditions are far from any allergic condition. So this can be misleading. That's number one. Number two is that serum total IgE can only be used in very selected conditions, like when you want to calculate the dose of the omalizumab therapy, or as a diagnostic and monitoring parameter in the ABPA, and as an assessment parameter in algorithms to predict reactivity food challenge testing. These are the only few specific indications of measuring total IgE. Otherwise, total IgE has no indication in specifically diagnosing the allergic diseases. Rather, it can mislead a physician in the diagnosis. The better screening test is a FADIA-TOP. Now, what is FADIA-TOP? Say we need to find out an answer to it. A patient has come and is giving the history, which seems to be a food allergy, maybe a rhinitis. And when we are not very sure that whether it's a allergic or a non-allergic rhinitis, or the symptoms, whether it's related to food allergy, or maybe some allergic disorder, we are not very sure. The history is not very clear. So in that case, we need to know whether this individual is really an atopic individual. We want the answer only yes or no. If it is yes, we proceed forward in doing the detailed allergic workup. If no, then we start thinking of something else, which is non-allergic disease. So FADIA-TOP is basically a screening test where it is also a solid phase immunoassay. And there are two FADIA-TOP tests. One is FADIA-TOP infant, and another is a FADIA-TOP. And this FADIA-TOP infant, the sensitivity and specificity is very high, more than 90% sensitivity, more than 80% specificity. FADIA-TOP sensitivity, specificity, both are very, very high. So what is the sensitivity? Sensitivity is the probability that a person having a disease will have a test positive to it. Right? So that means if it is more than 90%, that means if a person is having a disease, there's 90% chance that the FADIA-TOP will be positive. And specificity is the probability of having a negative test in those who do not have the disease. That means if it is very highly specific, that means those who do not have the disease won't show a positive result for this FADIA-TOP. FADIA-TOP is actually the measurement of a mixture. They use a mixture of the IgEs, specific IgEs. Usually the manufacturer does not disclose us what mixture they're using. That is their trade secret. But one can very well think that in case of the infants are mostly sensitized to the food allergens and maybe one or two aeroallergens. But in case of adults, it is mostly the aeroallergens like the house dust mite or tree pollen or grass pollen, along with that one or two food allergens. So basically, this mixture It is tested, patient's sample is added in the solid phase assay, and if there is the IgE to any of these items, it will come out to be positive. So it only says positive or negative. So the screening a patient with a Phadia is much more prudent rather than doing a total IgE, because total IgE can give misleading results. See, this is what you see. The significantly higher efficiency in total IgE. It was published in International Journal of Pediatrics in 2009. With the Phadia infant, the sensitivity is 98 and specificity 89%. On the other hand, the total IgE, the sensitivity is only 50% and 80% is the specificity. That means in respiratory allergies, only about 50% of the patients have increased total IgE. That is, half of the patients will not be identified by total IgE testing in cases of the respiratory allergies. And as you have seen, the increased total IgE can lead to other causes rather than the allergy, which we have just enumerated before. So how to use an immunocare Phadia? So if the patient has come with allergy-like symptoms, we take the history. If we suspect allergy, we do atopic reading by Phadia infant. If it is negative, then we think of some other causes. If it is positive, then the symptoms are most probably caused by the IgE-mediated allergy, and we then try to identify the symptom-provoking allergens by doing the immunocap whole allergen testing. So next we come to the immunocap. So again, we have multiple allergens in the immunocap profile, which can be pollens, food, drugs, mites, and which we test, and we select a specific panel, maybe depending upon the patient's history, or it's better always to select the individual allergens after the patient's history, and then correlating it with the pollen calendar. We should select the individual specific allergens which needs to be tested, rather than going for the preset panels like the eczema panel or rhinitis panel. It's always better we take a detailed history, select the allergens which needed to be tested, and then we do the immunocap. The only disadvantage with the immunocap is that we do not have the immunocap allergens to all the local allergens which is prevalent in our country. So in that aspect, we have only skin prick test, or otherwise we have to go for the non-standardized method of detecting the specific IgE, like the ELISA or the KV luminescence methods. So first of all, we do an allergy screening at the immunocap Phadia or the Phadia infant, or now we have immunocap rapid also. Then we do the allergen source identification by the immunocap. So we are now they are increasing the number of allergens in their basket. So maybe with time they will include the allergens which is prevalent in India also. After that, if we need to detect, if we're thinking of there could be a cross reactivity between a particular allergen, and say we know there's the tropomyosin, which is present in the cockroach, which is present in the shrimp allergy, in the house dust mite, which we call tropical triangle. So if there is a sensitization to the tropomyosin, then the cockroach will also show positive, shellfish will also show positive, but there we may not be sure that whether it is actually due to what. So in that cases, we need to resort to the component testing. This is called component resolved diagnostics. So though it is still not very much available in India, but we're getting that. We're getting it maybe within a year or so, it will be available to us. Similarly, to many food allergens, and like the nut allergens, we have to do the component resolved diagnostics to actually identify the actual allergen to which we are allergic to, and so that we can rule out the cross-reactive allergen. Similarly, in the insect venom allergy, we usually resort to the component resolved diagnostics. It's where we can rule out the cross-reactive domains giving rise to the positive test and identify the true allergy. So that is the component testing, and the latest thing in that is the ISAC, that is the protein identifying multiplexing. where there's microchips and which is used to identify the actual proteins. These are not yet available in our country, but it will help to identify the true allergies when and we are not able to elicit very proper history from the patient. So, what's causing the symptoms first, then what is the future risk, and then what should or can I do? So the questions which should be in our mind is that, is the patient atopic or not? What is causing the symptoms? What drives the sensitization? What is the risk of severe clinical reactions? And is the sensitization in progress? And all these things are answered by the proper in vitro testing, like using an immunocap method, and then interpreting the results. So in summary, in vitro allergy test should always be interpreted with clinical history of the patient. That is the first and the foremost important thing. And if you falter in this step, then the entire thing will go wrong and will end up in interpreting wrongly. The patient ends up in understanding the result. They get confused, and this all ends up in giving a bad name to the specialty. Why? Because the specialty and the way and what is being tested, the results that we're getting, they're absolutely okay. But it is the interpretation which is wrong because of the improper training or lack of training of the particular physician that is causing the confusion. There are a number of allergens available in vitro portfolio, and it is increasing. So in vitro allergy diagnostics help in diagnosis, prognosis, and planning the treatment plan of the patient. And immunocap is recognized as gold standard in vitro diagnosis.
Thank you to the ICS and also for the support for this particular webinar to Sanofi. And the topic you have selected is Aerobiology of outdoor allergens. Why you have selected is that allergens is directly related to the allergic diseases. Anything that causes allergy is considered to be allergen. So today's agenda includes what is aerobiology, aerobiological monitoring of the important allergens in India, pollen and fungal calendars of India, which are used to be as a diagnostic and therapeutic tool, allergen cross-reactivity, impact of climate on pollen allergens, and finally I'll conclude the overall presentation. So today the need for that approaches that have been established to manage or treat the respiratory allergic patients that include several steps. For example, this allergen avoidance is the first and foremost method of controlling the allergic diseases. If you know to what the patient is allergic to, we can manage to some extent with the best form of treatment. But it is very difficult to find out to what the patient is allergic to, particularly those which are present in the environment. You can avoid foods, you can avoid some other contact allergens, but difficult for inhalant allergens. Similarly, next is the suppression of symptoms, which is a pharmacological management. Then allergen-specific allergen immunotherapy, that is immunomodulator that change the natural course of the disease, and patient and physician awareness about the disease. However, the effectiveness of these strategies depends on the thorough understanding and knowledge of the local aerobiology of the region, of the country, of a state, or a locality, or a district, depending on where the patient is residing. So what is aerobiology? Some of our friends would like to say, aerobiology is nothing, as the subject is, term itself indicates. Aerobiology means biology of the air, biology of the environment. So this has been defined as a scientific discipline focused on source, transport, and dissemination of biologically important allergens, such as fungal spores, pollen grains, dust mites, insects, foods, etc., by the atmosphere, including its impact either on the plant system, animal system, or the human system. However, abiotic or the inorganic pollutants are the gases, for example, carbon dioxide, nitrogen oxide, or ozone, affecting the living organisms are also currently included into the concept of aerobiology because they exist in the environment or in the air together. Air pollutants are there, pollen or biological materials are there in the atmosphere. So they have got the interaction. That's why they have got a synergistic effect, not only on the pollen allergens, but also on the human respiratory system. What is allergen? Very common word being used. Allergen means clinically the term is often used for the source of allergenic molecule or the factors that affect the symptoms. For example, pollen grains, fungi, dust mites, insects, animal epithelia, foods, drugs, anything. But technically or immunologically, the term allergen is used for an antigen which causes type 1 allergic reaction. And there are no physiological differences between the allergens and any high molecular weight protein. However, the allergenic activity of these allergens or the proteins or the molecules depends on the configuration of the proteins or the characteristics of the proteins used. So entire protein may not be allergenic. A part of the protein, that is the epitope, which are looking for, which are important for allergenic properties. So in general, these allergens, actually common outdoor allergens and indoor allergens, they have been categorized into 4 groups. One is the inhalant, like pollen grains, fungal spores. They are basically airborne. We inhale them. That's why they are known as inhalants. Then ingestants like foods and drugs. They have also been categorized. Contactants like latex, trichomes, cosmetics, powders, etc. And injectables, both in the form of insects by injecting their venom, and also the drugs, maybe the penicillin or any other drug which is injected. So overall, the allergens have been classified into 4 different groups: inhalants, ingestant, contactants, and injectants. So now, day-to-day life, we are bombarded by various types of allergens in the atmosphere. For example, here is a pollen grain present in the atmosphere coming from various grasses and weeds, different seasons of the year. Then we have the molds. This is important for indoor as well as the outdoor allergens. Dust mites basically is the indoor allergen. Then you have the dust, you animal epithelia, insects and debris, foods, drugs, anything in and around us. But I will be focusing mostly on pollen and mold allergens. India being one of the richest flora on the earth, actually, it has got a very wide fauna and flora across the country. And accordingly, the varies actually fauna and flora, right from Thar Desert in the Rajasthan to the alpine tundra in the Himalayas or the Gangetic Plains in the northern part of the country. You can see if you go to the Himalayan region, you will find different types of fauna like pinus, alder, birch, and so on. If you go to the coastal areas like Bombay, Calcutta, Chennai, Trivandrum, you will find coconut, you will find that, and that's why the local pollen emanating from those patients who are exposed to the local pollen, they are more, at risk for developing the allergic symptoms to those pollen rather than those residing away from those plants. Similarly, in the Thar Desert, there is a different type of fauna and flora like Prosopis, we commonly call it as a kikar, or the Salvadora. They are the important allergens in the desert region. And in the Gangetic Plains, actually, many of them are common. Most of the grasses and crop materials, they contribute to the allergens. So variable pollen concentration and season is recorded from different ecozones of India. Accordingly, the symptoms of allergy patients is also variable from one part of the country to the other. The entire aerobiological pathway has been actually classified into 2 forms. One is a classical aerobiological pathway. We also call it fundamental pathway. Here you can see here they have the source materials of these allergens in the form of plants, animals, or insects, and they release their antigenic material in the form of pollen grains, fungal spore, or dust mites into the air, and ultimately they get dispersed into the atmosphere or the air from varying from few hours to several days in the. And then ultimately they get deposited depending on the shape and size of these bioparticulate matters, whether it's a pollen grains or fungal spores, and they finally get deposited either on the man system or the animal system, plant system, or on the rooftops. And each of these stages are regularly influenced by the various meteorological parameters like temperature, relative humidity. This is a classical aerobiological pathway. These pollen and fungal spores, once they go to the atmosphere, they do not go to cause allergic diseases. They are doing their natural course and they are maintaining their progeny. But once they are present in the atmosphere, they are there after releasing at the suitable season and time when there is a flowering, we inhale them and they penetrate our airways either through the nose, through the mouth, through the conjunctiva, or through the skin. These are the common parts of the body to which these allergens penetrate in our system. And ultimately, they get eliminated. In the nose, actually, they get in whenever you are sneezing or coughing or coughing, they go out. But those which are retained into the system, they ultimately cause the allergic system. Why only 10 to 20% or maybe 30% people suffer from allergic diseases? They are genetically predisposed. Whereas the other people, the phenomena is going on. In the same room, there are several people, there's pollen. We are also exposed to those pollen, the other, but they do not carry the risk of developing allergy because of their genetic status. So practical significance of these allergen monitoring, either at the international level, national level, or regional or local level, is because they provide clue to potential allergens to which patients are exposed to. You know, if patient is coming to us in the month of March and April, we must know what are the important pollen grains present in the atmosphere or mold spores into the atmosphere during that period. That provides us clue to select the appropriate allergens for diagnostic purposes. The manufacturers provide 200, 300 list of allergens, but they are all relevant? No. Only those which can be clinically correlated with the good medical history of the patient, they should be selected to see the role of IgA antibodies in that patient. So it provides also a regular exposure trend. The aerobiological monitoring being conducted every day and every month and every year. They are established monitoring center for public and patient awareness. It also provides short-term exposure loads, particularly you must have experienced in the Delhi area during the winter months or the forming dust in the March and April. In short-term exposure, there is a sudden exposure of the load of the patients visiting to the OPDs or in the emergency wards with the shortness of breath. It is because of the pollution, because of the smoke during that period, that aerobiological monitoring can help them to decide what are the various factors. It also helps in evaluation of effectiveness of allergen immunotherapy. Also, it helps in assessing the cross-reacting allergens, whether it's a pollen fruit syndrome or pollen syndrome. And also to take awareness. If you know a particular tree, when it is flowering, what is the concentration peak period, if you can avoid by going near that particular plant or moving out of that area, probably that can also help to some extent minimizing the exposure to that allergen. Monitoring outdoor allergens from the atmosphere, a variety of sampling devices are available. I will not go into those details. The most commonly and primitive method which was used long back has been discontinued. Very simple method containing two stainless steel plates in the top. There used to be a microslide in between with an adhesive material, and it gets left over for 24 hours. In the rooftop, actually 10 to 15 meters height. At the end of 24 hours every day, they used to take it out and study microscopically about the various parts. But this is basically biased against the heavy particulate matters and larger pollen grains and molds rather than smaller particulate matters. So this gives only the quality, not the quantitative, only the qualitative analysis of the various outdoor allergens. This has been discontinued, is no more used. But this is a barcode strap. You need not change every day. It is a volumetric sampler and it can quantify the actual concentration of the pollen or fungal spores into the atmosphere per cubic meter of the air. I will not go into the detail. This can run continuously for 7 days. And at the end of 7th day, one can take it out. There is a strip around and that moves uniformly for 7 days. Actually, you can cut into 7 equal pieces and they are representative for each day when there. This is a very good, this is for barcode slide sampler, this is a spot sampler or portable sampler. You can keep it in the room, you can keep in the bedroom, you can take in the classroom or occupational sites. This has been found to be very useful, particularly during the symptomatic days. Once the patient comes and every year they have got the symptoms in a particular season, it can be patients are allowed to expose these lights actually in their rooms or the workplace or the classrooms for the children, and for 3-4 days, and they are studied. So rather than having a 200 list of allergens which are present in the entire environment, ambient atmosphere, this gives exactly to what the patient or the child has been exposed to, and this has been also found to be very, very useful for the patients of allergic disease in a diagnostic tool. These pollen grains looks like to be very interesting feature. You can see some are porate, some are having spines, some are having wings, the molds. So based on their morphological features, they are identified to the genetic level or even up to the species level. I was also involved in having a sort of manual for aeroallergen monitoring standards in the Asia Pacific region, which was prepared by World Allergy Organization. And this is available on the World Allergy website, also available there. So very simple method is the details have been explained how to and what are the various sampling devices and how to expose the slides, how to counter these pollen grains into the atmosphere is available. An All India coordinated project we had carried out about a decade back with the funding from the Ministry of Environment and Indian Council of Medical Research, and to find out a national map of the important outdoor allergens in the country. You can see the red spot, actually they are the one aerobiological centers where the monitoring for airborne pollen with the uniform sampling devices I told you, Burkhardt trap, was carried out with uniform methods, uniform sampling devices and uniform technique. And the pollen allergens identified in these regions were assessed for their clinical relevance or their clinical nature, both by immunological methods as well as by in vivo method skin prick test in the respective areas. So we had 5 medical centers. The blue centers, you can say one was in Delhi VP Chest Institute, other was in PGI Chandigarh. Then there was a center in Calcutta, there was a center in Bangalore and Trivandrum. These were the places wherever the expertise was available. The local allergens in South India were tested at Bangalore and Trivandrum. In North India, they were tested right from the Himalayan region also. They were tested at Delhi as well as in PGI Chandigarh. And the eastern part of the country, they were tested at Calcutta to find out their new allergens. So seasonal variations, actually, you can see here in Delhi, we carried out being a huge city in 4 different sampling sites were occurred in the north zone of Delhi, south, east, and west part of the country. So you say that 2 major seasons can be identified in the northern part of the country. One is the March and April. Here you can see very high concentration, mostly influenced by the tree flowering, and pollen grains from the tree elements are most predominantly present in the month of March and April as we encountered. So accordingly, even there is a good association between pollen concentration these months as well as the patients coming from these areas actually having the tree pollen allergy. After the rains, actually, of the July, August, September, actually, is a use again. There is another season of September, October, mostly predominated by the grasses and weeds pollen. Although in India, pollen are present throughout the year, contrary to the western part of the world, where only during the spring and autumn the pollen are present, and other winter months hardly there is any pollen in their atmosphere. So we have studied the important allergens of different months of the country. For example, most of the grasses, as I told you, there is a quantitative differences in the concentration of these pollen grains in different sites, actually, depending on the local vegetation. But one thing is very common, the peak period comes in the month of September and October for grasses. Whereas the richness comes, just to give you one example, there's a castor-bean pollen, most predominantly March and April. One of the recent studies conducted at Chandigarh very recently, published in 2000, data from 2018-19 and 19-20 for 2 years data. They have demonstrated as Morus alba, that is mulberry pollen or shahtoot pollen, they are almost 67%, 76% was in 18-19 and 57% in 19-20, it is reduced. So, but by an average, highest concentration, about more than 66% has been recorded for Morus pollen. I'm not able to use absolute pollen, how they have done it, followed by other pollen allergens like poaceae, this yellow one, then eucalyptus, then there are celtis, and the Parthenium hysteroporus little bit. But the majority of the 2/3 of the pollen grains, they have recorded it from the Morus pollen. This is, I don't know what's clinical relevance. Even at Vallabhbhai Patel Chest Institute, atmospheric pollen count in northern region of the Delhi has been regularly carried out for the last 3-4 years. And this pollen, as the gate, actually they are displayed, but this is total pollen count, whatever is there. This does not distinguish between the different allergens actually. So total pollen concentration as a patient awareness program is being installed. You can see here this again workout track which runs continuously for 7 days. At the end of 7 days, it should change, as I told you. So they also compared the earlier studies by me as well as this is the 2 studies conducted by us long back, and this recent data which they have carried out in 2017 actually. Some new pollen allergens been added, whereas the other pollen qualitatively and quantitatively have been reduced. Friends, the word allergen also, we are also interested what are the allergens in different parts of the world, outdoor allergens. So with that point in mind, World Atlas of Aeroallergens was prepared by World Allergy Organization, of which I also happen to be a part of it. And they divide the entire world actually into 5 different groups. Region A, containing this North America, then South America, region B, Africa, region C, European countries in region D, and Asia Pacific region E. So if you are interested in Asia Pacific region, like I clicked the Asia Pacific region E, you find the information from India, Thailand, Australia, and New Zealand. Some other smaller countries, hardly any information on outdoor allergens by monitoring is being carried out, except these countries, including Malaysia and other things. They have only recently started this. So once you are interested in the Indian pollen, if you click the Indian pollen actually on the website, you'll find this list actually important allergens based upon our work. This they have arbitrarily divided into 3 seasons: spring, autumn, and winter. In the spring season, here is a list of important grasses. This is helpful to the clinicians if patient comes in the month of February, March, or April. During the spring, these are the important grasses. I will not name them like Sanodon, Dichanthium, Paretus, so on and so forth. These are the important weeds. They are the one to be tested rather than something which is present in the winter months or other months of the year, because patient is getting symptoms during these periods. These are the relevant allergens rather than the other. Similarly, patient is coming in the autumn. These are the important allergens. So this has been found to be an important tool for the patient. Now, how to select a short and relevant pollen allergens panel for testing purposes? About 20-25% of the patients actually suffer from pollen allergy or pollenosis. And most of the grasses pollen actually have been divided into major 3 groups. That is grass pollen, wheat pollen, and tree pollen allergens. Now, is it necessary to test with all the pollen supplied by manufacturers, as I told you, in 200 or 300 list of allergens? To my mind, it's not. For example, what are the things to be kept in mind is local prevalence in different parts of the country. As I told you, the pollen flora varies from one part of the country to you will find in the coastal areas. Different pollen you'll find in the Himalayas, where from the patient is coming to you. So you have to focus on what is there in the patient's environment. Similarly, knowledge of cross-reactivity. The pollen actually cross-reactivity, I will just take you actually what is the difference between cross-reactivity and co-sensitization. I will in the future slides. So these ones, based on our studies, we have published a pollen calendar of different states of India. Data from where we had collected about 12 different states, it has been compiled into the form of calendars like this one. The green line shows the start of the pollen season, yellow color shows the peak pollen season, and red means towards the end. Means 10% this side and 10%, 80% of the pollen actually comes during this yellow zone. So depending on the good clinical history of the patient, you have to select the appropriate allergens. And these pollen calendars, they have been actually, these are the names by the international names or botanical names, and these are local. So from all the 12 states, if the pollen calendar is from Karnataka, you will find the Kannada name. If it is from Maharashtra, it is Marathi name. So vernacular name, because you are interacting with the patients with the local vernacular name. So you must know what exactly, Chenopodium, allergen. If you call physiopodium, people will not, neither the patient will understand, and to some extent even doctors do not know. But it's a common vatwa. Every day in Indian language, in the North India, it is being used as a vegetable. Similarly, how the pollen calendars are different from one, I will not go into the details, but this is the pollen calendar from Himalayan region. A very crisp, very well identified peak season rather than having a perennial flowering pattern. Recently, based on the studies conducted in 1819, as I told you from Chandigarh, one group has actually also prepared a recent calendar for pollen allergens from the Chandigarh region. These informations actually we have published in the form of book, actually important, atlas of important pollen allergens of the Indian origin. Actually, you can see these grasses are different than what the manufacturers from Western world have been advocating. You won't find these allergens ever, and our patients are exposed to local agar. For example, this is Sankras. So its pollen distribution is reported from different parts of India, flowering season July to August. So this, if you interact with the patients, is it such a grass is around your place, when does it flower, like Imperata cylindrica, then you can select the most appropriate, and the therapeutic management also becomes more efficient and effective. This is the doob grass, actually, lawn grass, actually, Sandodon dactylan. This is a sort of ubiquitous, you will find, this is also known as Bermuda grass or the doob grass in Hindi, actually very common. So its season, its allergenic properties, as well as its pictures are given in like this grasses. This is the tree in the form of a book. I don't know that book I have not mentioned. This has been published, about 100 plants actually have been published by me in the form of booklet. So the one can refer actually what are their season, what is their concentration, where do they are prevalent in the environment. As a patient and physician awareness, actually, European pollen network, actually, this outdoor allergens, pollen is the most important. There are 188 centers in the entire Europe, coming from UK, from Italy, from France, from Germany, and they total together, and these informations are made every day available on the print media as well as from the electronic media in the news broadcasts, other things, they are available to the patients as well as physicians so that they can take preventive measures. Similarly, US pollen network is again about 82 centers are there across the US, and this data is again made available through the Academy of Allergy, Asthma and Immunology to various parts of the USA. Similarly, Australia and New Zealand also, they are coming regular monitoring for the last several years. Unfortunately, in India, we do not have a system. Only recently, as I told you, the Pallabhai Patel chest one sampler has been installed. Earlier, whatever work was done, that was done for 3 years, 4 years, and then once this is discontinued. But now it is being regularly monitored. I hope in future they will be able to identify individual allergens rather than the total pollen grains. New emerging pollen allergens, a word about it, based on in vivo and in vitro studies, we conducted some allergens. As a result of this All India monitoring of pollen allergens, we found there are some allergens which pollen grains are present in the atmosphere in very high concentrations, and we do not know their allergenic potentialities in the local patients. It is with that reason, for example, Himachal Pradesh has got a different list of allergens from Nauni, Solan, and other parts of the Himachal Pradesh. We conducted and find out different allergens like Alnas, Bud pollen, Albizia, Betula, so on and so forth. So we tested them at 2 different centers like Chandigarh and Kai, because they are in the foothills of Himalayas. And we found that Alnas nitida, Betula, Cedrus, Melotus, Quercus, they are allergenic plants in the local population, mostly coming from the Himalayan region. This has been already published, this data is on. Another very scary scene is coming up because olive tree plantation in India. Olive pollen is a very, very strong allergen in European countries, and in India does not have the olive plantations. Only recently, for the last couple of years, it has been introduced with the point to keep the India's plan to become leading olive producer in the country. So in Rajasthan and some parts of the adjoining areas, a huge plantation is going on. More than 1.5 lakh olive trees have been planted in the Rajasthan, Gujarat and Maharashtra area. Since we know that olive allergens is doing havoc in the Western population, so before that we should have studied the allergenic properties of these plants in India. Although it is molecular level, Olea europaea 1, which has been characterized to an important component, has been found to be important allergens. And you can see the other side here, it is being planted in Bikaner, Nagaur, Jaipur, Jhunjhunu, so many areas of the Rajasthan desert. So, I mean, this may prove to be in future, probably, I don't know how the Indian patients will behave. For example, Parthenium hysteroporus, the Congress grass, this was introduced accidentally some 35, 40 years back in the country. And now it is almost naturalized, it was not there. But now it is a huge problem, respiratory problem, not only respiratory problem, but also the agricultural problem as well. A word about allergen cross-reactivity, very commonly used rather than this, the cross-react. By very simple word, cross-reactivity means there are two ways. That is chemical nature of chemical proteins, they are common or similar to the other plant materials. That's why they show the sensitization pattern or that may be clinically relevant or may not be clinically relevant. So the patients who are consulting the allergist usually have sensitization 2 or more allergens at a time. We call them polysensitized. Documented by either skin prick test or by measuring the allergen specific IgE bodies in the sera of the patients. Polysensitization may result due to co-sensitization. Means at the same time this IgE reactivity and skin prick test or by measurement of IgE antibodies, multiple unrelated sensitizations arise. Grass से भी मिलेगा, pollen से मिलेगा, mold से भी मिलेगा, house dust, everything can, so many allergens to be positive. So that is known as co-sensitized. They may not be the same. Whereas the cross-reactivity reactions in which IgE antibodies are virginally raised against a particular allergen and they bind to a similar or homologous proteins of another allergens. Either maybe another member of the same family of the plant, or maybe some animal family, or maybe some, they are known as pan-allergens actually. They are the cross, here the homogeneity of the homologous proteins, they are present, they may be clinically relevant or may not be clinically relevant. I'll just give you one example of Holoptilia and Tigrifolia pollen. On the top you can see this is a chilbill pollen, commonly we call, this is the period actually month of March and April. In northern India, most of the trees, there are not a single leaf you will find fully blooms, and sometimes the pollen comes like a dust. And this belongs to the family Urticaceae. Similarly, another plant is here, Paetoria judaica. This also belongs to the Paetoria judaica is very important allergen in Europe, like particularly in Mediterranean Europe. And Holoptilia is important allergen for India, very, very important allergen for India. Holoptilia doesn't exist in Europe. Paetoria doesn't exist in India. But what is the cross-reactivity? Because both belong to the same group. So see the study of cross-reactivity. We did some immunological as well as in vivo studies. Just to give you an example, for example, when we measured the IgE antibodies in the Holoptilia sensitive cases from India, with the Paetoria judaica, there is a specific IgE antibodies present in the Indian patient sera. Even beside here, this is the almost 70 to 80% of the patients also show the sensitization pattern or the presence of IgE antibodies against Paetoria judaica also, Indian patient sera. On the contrary, when the sera from the European patients with the collaboration of Dr. Panjani was used, you can see this black spot, these are growing concentration of different patients, specific IgE levels against the Paetoria judaica. But when they were challenged, we find out the IgE antibodies against Holoptilia, because both belong to the same, hardly any IgE antibodies against Holoptilia is present in the patients of the European sera. See, it shows if the patient of Holoptilia goes to the Europe, he is likely to get the symptoms because there is a 70 to 60 to 70% correlation in IgE antibodies. But if the patient suffering from Paetoria judaica comes to India, he may not have any fear, because that antibodies actually which are specific to Praeterea judaica is absent in Holoptilia antigripper. That is the advantage of knowing the cross reactivity. This was further proved by the ELISA and Ipsen studies. A word about the impact of climate change on allergens. The question arises, does the climate change also affect the pollen allergens? The studies conducted so far in different parts of the world does prove that a number of studies have revealed that impact of climate change and the global warming on aeroallergens such as pollen and modes is of enormous clinical significance for allergic patients. The rapid increase in incidence is also partly in allergic diseases attributed to this phenomena because of the increasing concentration of carbon dioxide and increasing temperature that leads to the higher concentration of pollen allergens, as well as duration is enlarged. So there is a high exposure of the allergens to the patients, and severity is also increased and duration is also increased. Just to give you one more example of the impact of on the ragweed pollen, actually is the study conducted from Viney from US. You can see pollen concentration of grains per cubic meter at 350 carbon dioxide ppm actually, and 700. This is the ambient concentration, 300 to 350 ppm of the carbon dioxide in the normal ambient atmosphere. Was the plants growing here, and the plants growing at 700 ppm, they show the concentration of pollen is increased. Means with the increasing global temperature, there is a likelihood of more and more pollen exposure or the allergen exposure to the patients. Studies conducted over a long period of 20 to 30 years or 40 years indicates here from 1970 to almost 2010 here shows the plants which used to flower on the 5th day of the year, January taking the first day, and the 5th day of the year, they have started flowering now on the 17th. So there, on an average, there is an advancement half a day every year in the flowering of these plants. They use flower earlier and they prolong for a longer duration. So longer duration of the pollen remains into the atmosphere. So is the case. Another example, increased annual pollen concentration reported from Denmark. There is a linear correlation with the increasing data from 1978 to 2000. You can see here gradually the pollen concentration at two different places studied were increasing. This is the impact of indirect impact of climate change. So impact of climate change also increasing sensitization pattern. You can see here from 1981, 2007, about 25 years actually data. So the concentration of pollen is gradually increasing. You can see the linear correlation gradually and ultimately, overall. And accordingly, in the same manner, in the same area, the sensitization pattern to these allergens, actually Praeterea judaica, is also increasing. This is an important factor. You can see here both. So increase in concentration of these allergens is also gradually leading to increased incidence of or sensitization pattern of allergic diseases. Then there is the pollen pollution interaction, as I told you, leads to the incidence of respiratory airborne pollen and pollutants coexist in the atmosphere, and recent increase in the incidence of respiratory allergy all over the world is partly attributed to the synergistic effect of pollutants on the human respiratory tract and also altering the antigenic properties or the allergenic properties of these pollen by interacting or by their synergistic effect. So the impact of pollutants on morphological and also immunological properties of pollen antigens has been established. I'll just give you one example. Effect of concentration here, you can see this ambrosia pollen here, and increased pollen allergen production, plant migration and spreading, changes in pollen transcription. These are the studies conducted with the effect of carbon dioxide. Similarly, birch pollen and phloem pollen, they also affect the increasing temperature. Carbon dioxide leads to increasing with higher concentration of pollen. We did some studies actually to find out the impact on the laboratory conditions, actually experimental studies. Exposure, we expose these pollen allergens under controlled conditions, glass chambers with sulfur dioxide, nitrogen dioxide from different durations and concentrations, right? From 100 microgram per to 500 microgram per cubic meter actually. with 8 hours exposure, 16 hours, 32 hours and 48 hours. So with the increasing duration and concentration, there is a detailed morphological features actually get distorted. The result, they release their antigenic materials or proteins actually in a much quicker manner. So we extracted the antigens from these and we found having the impact actually. Most of the antigenic materials, once you extract it, they come within 8 hours. In fact, the pollen antigen present in the surface wall of the pollen, they come out within even a few minutes. So we can conclude from this inquiry the very high degree of deformity in pollen morphology has been observed in the pollen exposed to different durations and concentrations of pollutants than the normal unexposed pollen grains. Total soluble protein and antigenic extracts were significantly increased in the exposed pollen of various concentrations and duration due to sulfur dioxide exposure. So most appreciable change in protein profile of the antigens was pollen exposed to SO2 and NO2 together because they have the synergistic effect. I will not take much time, another 2 minutes actually. A word about thunderstorm asthma due to pollen. You can see in Indian states have recorded 36,000 lightning strikes during the last 13 years. So what is thunderstorm asthma? It occurs not in only one individual or two individuals, it's multiple individuals at a time. Such events strike unexpectedly and with devastating suddenness. All of a sudden, there's a sudden strike of light and dust storms. The largest and most catastrophic of these occurred on November 21, 2016 at Melbourne, Australia. There is a well documented evidences are there. After the storm struck at 6 p.m., more than 3,500 patients across the Victoria state just had the respiratory distress. Actually, they reported to emergency rooms in different hospitals. Many more individuals were managed in the community or general hospitals or with the GPs. And during that catastrophe, 10 deaths had been traced to this epidemic in 2016 in Victoria. Means thunderstorm asthma, not much information is available in our country that needs to be looked into. How thunderstorm asthma occurs let me just give you. Here are the in the bottom, there are the flowering season, there are the grasses, weeds and trees. The whole pollen grade during the thunderstorm the grains get swept up to the upwards in the atmosphere, and with the cloud storms or when they matures, and they get fragmented. These pollen get fragmented into smaller particulate matters, and these smaller particulate matters on the downward terms, they come here, they penetrate, and they are fragmented structure. They are polymicronic forms They are less than 2.5 micron size. That's why they are capable of penetrating our respiratory tract and causing the thunderstorm asthma. So these polymicronic particles are the smallest particles, can penetrate deep into the airways and induce asthma in those sensitized atopic individuals as compared to non-atopic individuals. So allergen exposure, there is a limited data to allow assessment of the exact magnitude of the pollen during the thunderstorm asthma. In 3 events, it has been established. This is mostly the gross pollen in the European studies, which has been found to be cause of the thunderstorm asthma. One study noted marked spike in whole grass pollen grains, and what was described as empty pollen means these were polymicronic forms. They release all their smaller particulate matters and proteins into the atmosphere. Only husk of the pollen were remained. During 1994 London epidemic, there was a great spike in small inhalable particulate matters less than 2.9 micron size, and these are peaking as much as high as 1.30 lakhs particles per cubic meter. So friends, just to conclude, a rich pollen and fungal diversity in Indian environment has been established. More than 150 aerial pollen types and more than 200 fungi are isolated from the air, but only 10 to 15 types of different regions constitute almost 80 to 90% to the contribute to the air, and they are the ones which are clinically relevant for diagnostics as well as therapeutic purposes in allergic diseases. Two major pollen seasons during February to April and August to November are established through allergenic pollen, though allergenic pollen are present in the air throughout the, but these are the two peak periods. The first one dominated by trees and the second one is dominated by the grasses and weeds. The allergenicity of several indigenous pollen and fungi have been established with us, and they are still actually their antigenic extracts are not yet available for diagnostic and therapeutic purposes. So my humble request will be the pharma firms which come out in this field, they should include these ones which are already established allergenically important for further manufacturing and supply to the local patients. Need for assessment to establish thunderstorm asthma in India with evidence-based data. Continuous monitoring of airborne pollen in different geographical regions for patient as well physician awareness that like meteorological parameter of pollutants being made available on the print media as well as on the electronic media should be made available for the patients to take care of them while going out to have their inhalers in their pockets. So thank you very much for patient hearing. I hope I will not go into the fungus actually. This is what I was supposed to do. Thank you very much.
I think I would request Dr. Moitra to basically come again and just talk about anaphylaxis and also maybe just talk a little bit on anaphylaxis test that we do, in vitro testing of anaphylaxis.
Thank you. Yeah, is it visible right now?
Yeah.
And am I audible also?
Yes.
Okay. So thank you once again, Dr. Sonakar. This is anaphylaxis, as you know, that this is a life-threatening condition, and taking in the actually what we have learned in my first talk on the basic of immunology and allergy, we'll try to build upon this. So we have seen that what is a hypersensitivity reactions, because this is an exaggerated response of the immune system towards any external antigens. In type 1, we call it an allergen. So the original Jelen-Coombs classification holds good even today. That is, we have 4 traditional types of hypersensitivity reaction, type 1, 2, 3, and 4. Out of this, type 1, 2, and 3, they are all mediated by the antibodies, and type 4 reactions are mediated by the cells. So the type 1 is through the IgE, which we have just studied. And then the type 2, it is through the antibody IgG or IgM, which is produced again in cell surface as antigens, and this causes activation of the complement and inflammation. Type 3 is immune complex mediated. Again, there is soluble antigens towards which it gets attached to the IgM or the IgG, and they form the immune complexes which activates the complement. And type 4, as I have said, is mediated by the T lymphocytes. So anaphylaxis is the archetypal type 1 hypersensitivity reaction. It is being defined as a severe life-threatening systemic hypersensitivity reaction, which is characterized by these 2 points are very important. Number 1 is rapid in onset, and number 2 is potentially life-threatening, involves the airway, breathing or circulatory problems, and is usually, but not always, associated with the skin and the mucosal changes. So the diagnostic criteria for the anaphylaxis has been given by the WAO anaphylaxis guidance. It states that anaphylaxis is highly likely when any one of the following 2 criteria fulfill. What are them? Number 1 is the acute onset of illness with minutes to several hours with involvement of the skin or mucosal membrane or both, like having a hives or pruritus or flushing or swollen lips, tongue, uvula, which we call angioedema, and at least one of the following. Which is this one of the following? It could be either an airway or breathing or respiratory compromise, a patient presenting with the dyspnea, wheeze, bronchospasm, stridor, or there could be a circulatory compromise like reduced BP, associated symptoms of end organ dysfunction like hypotonia, collapse, syncope, incontinence, or C, that is the other severe GI symptoms like severe crampy abdominal pain, repetitive vomiting, especially after exposure to non-food allergens. So this could be the one. And second thing it could be an acute onset of hypotension And when we say hypotension in adults is BP of less than 90 mmHg or greater than 30% fall from the baseline. In children, low systolic BP, which is age specific, or greater than 30% decrease in the systolic BP, or there is the bronchospasm, or there is laryngeal involvement after exposure to a known or highly probable allergen for that patient, and happens rapidly, that is minutes to hours, even in the absence of typical skin involvement. So when these two criteria, any of the two, then we call it an anaphylaxis. We should always keep in mind the differential diagnosis. There are lots of differential diagnoses, but the important ones are acute asthma. It could be a cardiovascular event. It could be a neurological event. It could be any other things. The list is a big one. But obviously the typical signs and symptoms, it's direct us to make a proper diagnosis. Now we know that anaphylaxis, as I have said, though it is an archetypal type 1 hypersensitivity reaction, but which is IgE dependent, which is the most common form of the anaphylaxis, we can have a non-IgE dependent anaphylaxis also. The immunological mechanisms that are IgE dependent, it could be brought about by any food items like fish, soybean, egg, peanuts, fruits, milk, sesame, shellfish, anything, or medications like the NSAIDs, the biologic agents, the antibiotics. Apart from this, there could be radiocontrast media-induced anaphylaxis, which can be IgE dependent. It can be non-IgE dependent also. Occupational allergens, latex, aeroallergens, insect stings of the Hymenoptera group, order, then the seminal fluid. And there could be an immunologic mechanism which is IgE independent. It is IgE independent or non-IgE dependent mechanism. It could be IgG also. Now we are trying to understand IgG dependent mechanism anaphylaxis, which is radiocontrast media, NSAIDs, the dextrans, and the biologic agents. Or it could be non-immunologic mechanisms where there is no production or there is no involvement of the antibodies. There is direct mast cell activation through some receptors on the mast cell membranes, like the MRGPRX2 or similar receptors, and this can be seen with the ethanol, with some medications, like the fluoroquinolones or opioids or the physical factors. And there can be idiopathic anaphylaxis where no apparent trigger can be found out, but previously it could be an unrecognized allergen, or it could be an underlying clonal mast cell disorder, that is the mastocytosis. This is the types of anaphylaxis. So the mechanisms is whether it is an IgE dependent or IgE independent, or it is a direct activation of the mast cell, whatever it is, it causes the mast cell or the basophil activation. This causes a rapid release of large number of the mediators, which we were talking about in my first talk, and recruitment of the many other cells, namely the eosinophils, the T cells, the monocytes, and also platelets. And this leads on to secretion of the cytokines, the lipid mediators, the complements, the mast cell mediators like tryptase, histamine, heparin, platelet activating factor, or there could be the other mediators like the nitric oxide. And this leads on to the complement activation and kallikrein-kinin system activation, and causes the smooth muscle spasm, vasodilatation, decreased systemic vascular resistance, hypovolemia, increased permeability, and this is the anaphylaxis that we get. So this is the mechanism which is actually seen in cases of anaphylaxis, whether it is a immunologic or non-immunologic pathway. So the clinical feature of anaphylaxis, it could involve the skin and mucosa. Skin and mucosa, we get articular eruptions, the angioedema, and intestine there could be flushing, pruritus. The bronchopulmonary signs involvement leads on to laryngeal edema. There's a wheezing, there's a coughing, there's a rhinitis. The cardiac involvement can cause vasodilatation, reduce systemic vascular resistance, myocardial depression. GI, nausea, vomiting, diarrhea, intestinal edema, neurological dizziness, confusion, headache, feeling of impending doom. There's vision disturbances, uterine cramps, uterine bleeding, scrotal edema, urinary fecal incontinence. And so we can see that in anaphylaxis, it's a multi-system or systemic involvement, and it can involve any of the organ system because of the low perfusion state. There are multiple factors and the cofactors which can influence the anaphylaxis. The age-related factors, That is, in the infants, they cannot describe their symptoms. The adolescents and the young adults, they have high risk. They increase risk-taking behaviors, taking many drugs and any other, and then exercise and all. Labor and delivery, this is a time where there is risk from the medications, especially the antibiotics. And obviously the elderly group, that is increased risk of fatality from medications, and venom-triggered anaphylaxis as death is quite common in the elderly population. And along with that, the concomitant diseases. If there's asthma and other respiratory diseases, then dying from anaphylaxis could be high. Allergic rhinitis, eczema, psychiatric illnesses like the depression, and as I have said, the mastocytosis, that's the coronal mast cell disorder, cardiovascular diseases, and concurrent consumption of the medications like the ethanol, the recreational drug use. Beta blockers usually tend to mask the initial signs and symptoms of the anaphylaxis, ACE inhibitors and the NSAIDs, and obviously the ethanol, sedatives, hypnotics, antidepressant, and recreational drugs. All, if the patient is consuming, there's increased chances of having a fatal anaphylactic reaction, or chances of increased chances of having an anaphylaxis or anaphylactic reaction to various other triggers. Then there's some factors which amplify anaphylaxis. What is those? That's an exercise. So exercise is known to cause a direct activation and degranulation of the mast cells by a non-immunologic mechanisms. Acute infections like the cold or fever, the emotional stress, the disruption of the routine like having a long haul flights, and the premenstrual status in females, this can amplify the anaphylaxis. So the WHO systemic allergic reaction grading system, initially we had multiple other grading systems, like we had the Riemann-Mesmer grading system for the perioperative anaphylaxis. We had the Brown grading system for other drug-induced anaphylaxis, but this is a standard WHO World Allergy Organization systemic allergic reaction grading system. So if it's a grade 1 or 2, it is not an anaphylaxis. That is basically in the grade 1, the symptoms or signs from one organ system present, that the cutaneous, urticaria, and or tingling, upper respiratory tract symptoms, some throat clearing. When there's one organ system, it is not anaphylaxis, it is grade 1. Grade 2 is symptoms or signs from 2 or more organs. In anaphylaxis, it is grade 3, 4, and 5. So grade 3, there is a lower airway involvement and or GI involvement. Other system involvement can be there, like uterine cramps or any other symptoms from the grade 1 would be included. In grade 4, lower airway symptoms like severe bronchospasm, not responding or worsening in spite of the treatment, and or upper respiratory or the upper airway symptoms and laryngeal edema, stridor, and symptoms from the grade 1 and 3. And grade 5 is a severe one, and the worst, it is a lower upper airway, respiratory failure, then cardiovascular collapse, and or loss of consciousness, as the vasovagal is excluded in this, and any symptoms from the previous grade. So this is how we grade the anaphylaxis, as depending upon the standard protocol. So what are the diagnostic tests which is there in acute anaphylaxis? Always remember, acute anaphylaxis is a clinical diagnosis, but and we give the treatment. We do not wait for the test results. We start the treatment immediately because that is the life-saving. I will come to the treatment. But there are some diagnostic tests that in acute anaphylaxis, the serum tryptase level. Tryptase, as I have said, it is a mediator which is released from the mast cells. Its levels are increased from 15 minutes to 3 hours or even longer. We can measure tryptase because it stays in the blood for longer time. Histamine is also released, but its levels goes down very quickly, and usually it is difficult to measure serum histamine levels. We can have the urinary histamine levels, but that is of less utility than the serum tryptase. And usually within 3 hours after the onset of the symptoms, the peak levels is 1 to 2, between the 1 and 2 hours. And after the onset, with 36 to 40% remaining less than 11.4 milligrams per liter. It is always recommended that we should evaluate the baseline serum tryptase at least 24 hours after resolution of the anaphylaxis symptoms, even when the tryptase concentration during episodes remain within normal range, because there's a 2010 consensus equation was there. We say that the peak mast cell tryptase should be more than 1.2 into baseline tryptase plus 2 nanograms per ml. This is nanograms per ml. So which should be actually the level, and it is shown that this can give us that there's a rise in the tryptase in the initial phase of the reaction, and which confirms the diagnosis of the anaphylaxis. It's because it shows there is acute mast cell activation. So then we come to the management of the anaphylaxis. Always when we talk about anaphylaxis, we should think of injecting adrenaline or epinephrine. So anaphylaxis and adrenaline goes together. They are actually joined together. The A stands for anaphylaxis, A stands for adrenaline. So we do not talk of anaphylaxis if we can't talk of adrenaline. It has to be given intramuscularly into the vastus lateralis of the quadriceps, that is the anterolateral thigh, injected. And unfortunately, we do not have epinephrine auto-injector in our country, so which is definitely an unmet need, because we usually lose many anaphylaxis patients before they can reach any healthcare facility. And the position of the patient is important to his or her presenting features. Most patients can be placed in supine position during anaphylaxis unless there is a respiratory distress. Pregnant women can be placed in a semi-recumbent position. So benefit of elevation of lower extremities is controversial. It is not being done. This is how the steps that we should have written an emergency action plan for the patient, remove the exposure of the triggers, assess the ABC, that is the airway breathing circulation, as we all learn during our BLS and the ATLS training. We call for help and inject the epinephrine. So what is the dose? Dose is 0.01 milligrams per kg of 1 in 1000 solution. Maximum is 0.5 milligrams in adults and 0.3 milligrams in children. We should record the time of the dose and repeat every 5 to 15 minutes if needed. And most patients, they usually respond with 1 or 2 doses. We can place the patient on the backpack, and when indicated, we can give the high flow supplemental oxygen. Always you should then we should go for having establishing intravenous access and can give a normal saline rapidly. And if indicated at any time, a CPR may be needed to be done, and at frequent regular intervals, and monitor the patient's vital parameters. So the dose, as I have said, it is 0.01 milligrams per kg body weight and can be repeated every 5 to 15 minutes. It is an intramuscular dose. We do not give the intravenous dose because intravenous dose can cause potentially fatal arrhythmias. So it should not be given until and unless the patient is under a monitor. So the patient with anaphylaxis, they can have the symptoms of bronchoconstriction. So in the second line of treatment comes the inhaled short-acting beta-2 agonists. This can be given by the inhalation or the nebulization, but they are not an alternative to the repeated administration of the intramuscular activity. But that is the most important medicine to be given for the management. In case of upper airway obstruction, they can be considered nebulized epinephrine. At frequent intervals, the patient's vital parameters has to be monitored. And the other drugs that is there is the beta-2 adrenergic agonists, glucocorticoids, and antihistamines. The H1 antihistamines has a very limited role in the treatment of anaphylaxis, but can be helpful in relieving the cutaneous symptoms. But we should remember, we should not rapidly give the intravenous first-line antihistamines like chlorpheniramine, diphenhydramine, and because it can cause hypotension further. Glucocorticoids are very commonly used. The objective is to prevent the protracted symptoms, but they are not. They should not be actually. They cannot be in place of the adrenaline, because that is only for the late symptoms. And the patient with asthmatic symptoms, and also to prevent the biphasic reactions because of the late allergic responses, which we had talked before. So the long-term management of anaphylaxis, always when a patient is discharged, they should have a anaphylaxis as written action plan. We should try to understand that what were the triggers, and this anaphylaxis action plan education should be properly taught to the patient. And at times and later on, we might need to do an allergy skin test. But always remember, during an anaphylaxis, there is an exhaustion and of the mediators from the mast cells. If we want to do a skin prick test, that should be done 4 to 6 weeks after the episode, when usually the mast cell mediators gets replenished. We have to confirm the anaphylaxis triggers, so especially from the history and by the medicine prick test, and patients should be taught to avoid the triggers. It could be some medicines, it could be food, it could be a stinging insect at the venom. So all this has to be taken consideration. And for the venom-induced anaphylaxis, we have the option of the venom immunotherapy, which we'll be talking about in our immunotherapy lecture. So, in summary, anaphylaxis is the most severe allergic reaction. It involves multiple organ systems, can be caused by a number of triggers and conditions that we have seen. It could be food, it could be drug, it could be exercise, it could be radio contrast media, it could be a stinging insect, insect stings, and it is often not recognized and it is untreated. We usually tend to lose the patients. That's why we do not have any registry. Unfortunately, we do not have in our country which actually keeps a documentation of the death due to anaphylaxis, because most of the thing when of these incidences gets unnoticed and undetected if it is happening outside the ambit of a healthcare facility. So the early recognition, high index of suspicion, early removal of potential triggers, and administration of epinephrine, it is life-saving, and this has to be undertaken at each opportunity. Thank you very much.
Okay, thank you, Dr. Moitra, for again a lucid presentation on anaphylaxis, which is not much understood and has to be, of course, managed in quick time. So thank you, faculty. We are now at the end of, I think, our lectures, and thank you for just explaining all the topics, of course, very well. Then to move to, I think, questions by audience, and I would start with one question that has come up to Indranil, actually, Haldar. What is atopic march? If you can elaborate on that.
Okay. Rajesh, the term atopic march, also called the atopy march, refers to the natural history of atopic manifestations, which is characterized by the typical sequence of immunology, that is IgE antibody response, and clinical symptoms which may appear early in life, persist over years, decades, and often remit spontaneously. It may start in such a way that it starts in early childhood with atopic dermatitis or eczema in that way. It goes to food allergy or milk protein, food allergy in that way. Then often it involves the upper airways, that is allergic rhinitis, and then ultimately develops into asthma. The way that it moves forward is known as the atopic march.
And is there a way to prevent this atopic march by having some tests done and also treatment, so that it doesn't?
In early life, absolutely. In early life, a child who has developed atopic dermatitis and has food allergy, we should know that this is the atopic child. So these are the child who should be taken care of. And in fact, this skin, the abraded skin, because of this atopic dermatitis, again becomes a source where other antigens and others can be, and the child becomes hypersensitive. So there are some ways of prevention as you are asking. For example, normal delivery prevents development of atopy rather than cesarean section, or the odds of having atopy is more when there is a cesarean section, when the mother is not breastfeeding his early child, exposure to endogens in that way, and there are some other air pollutions. Air pollution also progresses, or rather aggravates the ways in which the atopic march progresses.
Yes, Indranil. So of course, early identification of atopic child and as following up will of course do a lot of prevention of this thing in adulthood. There is another question, Dr. Moitra, and just comes to that, whether this nasal provocation test is essential to prove allergy, because you have done that there is a term called sensitization and allergy. So, do you need this nasal provocation test so that you can do an allergen challenge and see if there is some also difference in nasal resistance, or is it just an experimental tool that is being done in some centers, but in a Western or in a European country, they do insist on this, and they've got a device also to test this. So do you just think that this is essential to test before we will give some allergen specific immunotherapy to the patient?
Yes, actually, the provocation test, that whether it is a bronchial provocation test or a nasal provocation test, which were used somewhat more before, but now they have taken a backseat. Why? Because first of all, it is said that it is the history and the finding of the specific IgE, and again correlating with the history, which is the most important and pathway how we diagnose that whether this patient is suffering from that specific allergen mediated disease. Now, to prove that, we do not need the provocation test, specific provocation test these days, because now it is being shown repeatedly that the history and the immunocap, they actually suffices for the diagnosis. In the days to come, this provocation test will again and maybe become something of a history, because we are coming up here now. We will be finding this the immunocap Isaac panel. What is this Isaac panel is coming up? This Isaac panel, it not only says that which is the specific IgE which is present, but which is the specific IgE which is clinically relevant in that particular. So with that, coming up with an Isaac panel, this is merely a blood test, which is an in vitro test, and where there is actually no risk to the patient. So that means this test is going to actually prove ourselves when we are not very sure about the history, when there is polysensitization, and mostly when we are not able to get a proper history and correlate it with the test. With Isaac panel is going to suffice for that. So this provocation test, nasal provocation test, we do not need to prove an allergenic trigger for a particular allergic rhinitis. It is only the history and specific IgE, and maybe if it is needed, we can use the Isaac panel, which will be available to us very shortly.
Yeah, so definitely this will actually help in allergen-specific immunotherapy, and since immunotherapy is coming in also next modules, we won't just talk much on that. So actually there are a lot of questions on skin prick tests, because not just many pulmonologists in fact are very convinced about doing this test because of, I think, various reasons. So I think, what are the challenges that you find, Dr. Indranil, when you do the skin prick test in India, because of lack of absence of standard allergens, or also the shelf life, or of something else that you would like to see, and then what you would how you advise a person who would like to do this test in his own hospital, and how to really start it?
So Rajesh, skin prick test is thought to be the gold standard in doing the test, though I don't know many people are in the favor of immunocap test. They think that immunocap probably is as good as a skin prick test, and what Dr. Shaibal told, that probably it will be replacing the Isaac test, will be replacing some other skin prick test. So still now, I think that skin prick test comes to be the gold standard. But the real challenge which you really highlighted is getting a standardized antigen. The standardized antigen is very difficult. Second is, again, it all depends upon the history. How we are taken the history, how we are narrowing down our antigen, and to find out what the real antigen is according to the place where it resides, that is geographical area, the seasonal changes and all those, and who are giving us this antigen, how they are delivering us this antigen, and how we are storing those antigen, the self life as you call, and what is the temperature we are doing, and again the procedure of the test. Again, the procedure of the test is also very important. What lancet we are using, how we are pricking, and the expertise of the person that who is doing the test. In fact, what happens in most of the places, I have seen that the doctor do not do the test, and they keep a technician to do the test, and the technician is not very well conversant with the biology and what they have to do. Second is interpreting of the test. Again, as Dr. Shaibal repeatedly told, that once the test is done, so history and examination is important before the test, and once the test is done, again we have to sit with the patient, look into the history, and the thing have to be re-evaluated to find out whether this test is validated or not again. So sensitivity and specificity of a test is also very important in reinterpreting, because when we are testing food allergen, in fact, I have seen a number of tests where they are doing food allergens in skin prick test, and the subject is going to restrict about say 20 foods, and important foods that they are restricting, starting from milk to vegetables, everything, because they say, doctor, I have an allergy to all this. When I ask them, have you ever taken those food? Yes, doctor, I have taken those food previously, nothing happened. This is the answer that we get. So interpreting the sensitivity and specificity of food allergen is also an important thing that we should take into account. And lastly,
so another related question to this is how to choose antigens to test. So actually we got array of antigens, you've got so many antigens and you can't choose. So I mean, just which antigens to put, how to really go out, just sort of.
So again,
person.
A single line answer, the bottom line should be a good history taking and examination. The geography and the season on which the person and where the subject experienced this allergic symptom, that is very important.
So I would just come to Dr. Singh, in fact, about this antigen testing and also standard antigens which are available in India. Are they matching to the international standard, or is it are they standardized? Because there is no way that we have got an ISI mark on that, or because I found that there are so many vendors actually for this, and then how to choose vertical, which is the best vendor, because there are questions I'm seeing in the chat box, and obviously we can't give them the name of the vendor, but still, how to just choose a vendor, and then what then you would look into that. I mean, is there any I'll again shift to Dr. Moitra about this. I mean, after you have been doing this test since so many days, in between we had, I think, one of the company which came with some standards, but then they just couldn't be able to sustain in India because of the cost which was there, which was almost 4 or 5 times that. I mean, we get it. So, I mean, do you have any idea how to just choose these allergens from actually a vendor, or is there any what to call standardization marks on that in which we can say this is really standardized allergen?
It is very important, because as Dr. Indranil has very rightly said, that the non-availability of the standard allergens is one of the big hurdles for doing a good skin prick test, apart from some other hurdles that we do not have an updated full vendor. So then what do we do? So it is important that the allergens, there should not be a batch-to-batch variation in the protein content of the allergens. Now we cannot see that. So there is a government body, that is the institute, that is the National Institute of Biologicals under the Ministry of the Health and the Family Welfare in Delhi, who are entrusted with actually evaluating the quality of the allergens, which is usually given by a particular manufacturer. And they usually do the quality checks every year, or maybe sooner. So we should always try before like procuring an allergen for testing for an Indian manufacturer, we should always try to have a look about the quality certificate which is issued to them by the National Institute of Biologicals, which should be an updated, recent NIB certificate. Because if the manufacturer is doing it rightly, and if the allergen and the quality is good, and if they are not getting denatured, there is not much batch-to-batch variation, they will definitely provide or show to the buyer or to any physician. They are bound to show that is the quality assurance certificate which is issued by the National Institute of Biologicals. This is how we can go about, and we can choose. So those manufacturers who can show a updated NIB quality certificate for the allergens, and that is also very important. And that quality certificate is actually it is for individual allergens, because it might be for the house dust mite, Dermatophagos tennis, Dermatophagos feroni. It might not be for some grass pollen. So it has to be mentioned over there the names of all the allergens, which is checked by the NIB team, and the certificate is given to them. That is how at least we can go.
Yes. So basically, there are challenges in doing it, but of course there is a body. And
may I add something, Dr. Sankar? Fortunately, I've been able to connect.
Yes, sir. I was asking you, but then you again went offline, so I had to.
Yeah, this is the problem today. I mean,
yeah, I know. I can understand.
Digital. I mean, your question was very, very valid in today's practice. And in fact, as so far as quality control is concerned, they are supposed to follow the guidelines of the Drug Controller Government of India. Some couple of years back, there was no control, there is no guidelines from the Government of India. But for the last 2-3 years, they constituted an expert committee of the allergists and other persons, and they have come up with the recommendation that a minimum amount of quality control, not the biological standardization, chemical standardization has to follow, and each manufacturer has to follow that. And that is the good quality allergens reproducible within 10 to 20% variability each year. Shelf life is 1 year for the liquid items and also for 3 years for the glycerated items. And that quality control does not include the biological standardization of allergens as is popular in the Europe and USA. Here only the protein content in that every batch should be reproducible, as well as total protein content, as well as there is the SDS page, protein profiling actually. So number of bands should be reproducible with 1 or 2 bands missing, and the major concern, the major allergenic bands should be present in that. But unfortunately, this is the Indian guidelines that does not include the biological standardization of allergens. But even those ones are also not being strictly adhered to by the manufacturers. You mentioned there are 4 manufacturers to name as of today in India, indigenous manufacturers. That is, one is Alcure Pharma based in Bahadurgarh, Haryana. One is LCT India. One is Curdisol in Bombay. Another one is Trivandrum by Biodiagnostic and Products Limited. But to my mind, only 2 are doing some good work. That is Curewell in Delhi, as well as the Curdisol in Itna. But there also there's a lot of variation from batch to batch and manufacturers to manufacturers. If you just take the same antigen from 2 different manufacturers, we'll find, I think Dr. Christopher has also published this work in one of the journals. So, I mean, there is a variability. We have been striving hard to follow. But as of today, there is no. One question was mentioned by you, how to select the appropriate allergens. This again, the good clinical history comes into the picture, depending whether the patient is of seasonal in nature, patient is of perennial in nature, or irregular. If it is a seasonal, you should have to look for some of the pollen grains and fungal spores prevalent during that atmosphere. So entire list of from 100 to 100 allergens can be cut down to 10-15 only. And we also make the aerobiological approach during the symptomatic period, 1 week or 10 days. We expose the slides through the portable samplers into the patient's environment or the work environment, whether it's office, workplace, or the occupational place, or a school, or even the indoor the houses. So they are the one, within 1 week, you find not more than 5 to 6 allergens he has been extensively exposed to, and they provide the clue. They must be selected for skin testing and further confirmation of the disease. Another, I would like to utilize this forum. Somebody mentioned the IgE estimation to anything and everything, right from dalmor to red wine, white wine, and food, even dhania ki patti, and that is actually, there's a very bad practice, distant practice being going on in the smaller places. And there are, I don't want to name those people, we have taken, consulted with them. So here they are going in the separate name. If they go to the south, they are also selling the different name. People are the easy victims. And you won't believe those physicians, they just reports of 200 allergens positive to every food, positive to every pollen. They just give it to the manufacturers. You prepare the vaccine according to your choice rather than prescribing that. And manufacturers are using and preparing those allergens according to their whim.
Again, he was dealing on a very interesting aspect that I really wanted to take it out, because we've got allergens for also male and also female cockroach. And perfume, I think the things which doesn't have any protein to test. So of course this is what's happening, and this also gives a bad name to allergy and immunology that is there. And I think the second thing that I wanted to bring out is about this test about Immunocap and RAS. So I think Dr. DJ, this is for you, and for in vitro testing, is Immunocap and and the rest is same. And now, do we have also selected allergens for this immunocup and rest, and how many allergens we can test? So, do you have any idea?
So-
Because we do see, pathology, lot of pathology advertising about allergy test, and now we have got chains of, I think, pathology. Dr. Singh would also agree that we got what we call commercialization of this test, because SPT is not available in each and every place. So they would go to this, they would just ask for a blood, and they would do array of tests. I think they do about 3 ml or 5 ml, and they'll give you about 200 tests. So how much is it valid?
Yeah. So, much like other things, Rajesh, here also there's a element of shopping and, availability of fancy things. But the question is that what is of value to the patient and to the physician? How knowledgeable is the physician to use it? These are the questions to ask. So, I think it is inappropriate to test for huge batteries of allergens. And as was alluded to by someone just a while ago, I don't think there should be more than 10 to 14 allergens that are tested. And they should be very intelligently selected. Of course, there's a basic panel, but other things should be very judiciously and carefully selected. And it should be in the context of use for allergen avoidance or for immunotherapy. If there's no intention to do these things, I don't think we should test.
Yes. I'm not able to see my chat. If you see any questions and if you want to answer, just a moment, I guess.
Rajesh, you have shared some other thing.
Oh, I'm sorry.
Sorry, don't do that.
Yes. So I think we are past our allotted time. In fact, more than 2 hours. And it was really a stimulating discussion, and I think a very good talks initiation of this web series. And then I would just go back to Dr. Saibal Mutra to then just tell us about the next module before we also summarize this module. Dr. Moitra.
Yeah, thank you. So, Dr. Sonakar, we come to the end of the module 1. So module 1 was basically a basic module where we discussed about the basics of the immunology and allergy, and also got an oversight of the how do we do testing in the allergenicity by skin prick tests and the various in vitro tests, and also means how the aerobiology is important in selecting the allergens. And so because that is how we select the allergens for the test, but we should always understand that the positive predictive value of this test is not very high, it is low. They have a high negative predictive values, but they don't have a high positive predictive values. So that is the most important thing, that these are not the tests, so we should be treated like any other test. But here the doctor, physician needs to sit with the patient, decide with the allergens, then test, and then again sit with the patient, second time, decide the allergens. That we understood quite well through the lectures of Dr. Haldar and Dr. Christopher. And we also just learned about one of the dreaded the allergy condition, that is the anaphylaxis, because the anaphylaxis awareness is of paramount importance for all of us, because so we tend to lose the patients of this dreaded disease because it goes under-recognized and under-treated. So in the next module is basically dedicated to the nasobronchial allergies, where we'll be having talks on the epidemiology of asthma and allergic airway diseases, and allergic, non-allergic rhinitis, the asthma, including the occupational allergies and the asthma. That will be the module 2, so which we'll be having shortly. And I thank you all who participated in this module. And I really thank the faculty, and I really thank Dr. Dhar, Dr. Sonakar, Dr. Christopher, and the Sanofi who actually helped us in delivering this entire session, and the Indian Chess Society, under whose banner this module has been created. Thank you all. Thank you very much.
Yeah, and I would request the audience to then also stay tuned and also look for our module 2. And it was a nice evening in which we started this allergy immunotherapy web events, and I hope that of you will also follow all the 4 web events that is that is going to be presented. Thank you all. Thank you all of you, and also stay safe. Bye bye for now. Thank you.
Thank you.